Well, good evening, everybody. Let's go ahead and get started. So some of you are familiar with my style of teaching. Some of you are not. I will make this as painless as possible, and I will change my format of delivery a little bit tonight. Normally, I like to engage in discussion. Tonight's going to be more type of lecture style, just because of the time constraint. We've got a lot of material to cover in just the amount of time we have. So there will be some things that I just don't have time to stop on. If you want to write the question down at the end, we can start answering them. But I really think we're going to be hard pressed to finish on time tonight. There's a ton of material. This PowerPoint lecture is not comprehensive. I do think it's covers a lot of bases, but there's still some stuff that you'll have to learn from either your book or other resources and materials. The problem you might run into is that you're taking a national certification exam, whether it be EMR, EMT, EMT-A, or paramedic. And the problem with that is that you're taught from the bias of Georgia paramedics and EMTs. The problem with that is they're going to have some questions from that polar bear riding guy from Alaska. They're going to have some problems with that Indiana Cornhusker fella. So you're not going to be taking just a Metro Atlanta EMS test. You're going to be taking a national test. So the rural medic, he's somebody you know how to work with. The Metro Atlanta medic who has a 10-minute transport time, that's something you need to be familiar with, those type of modalities. So again, tonight, we're going to take breaks. That way you have time to refresh, recharge. We'll probably be ordering some food here in a little bit. I'm hungry. It's going to happen. I'm going to eat. But other than that, I'm just going to start rolling through. Any questions for me before I get started? I encourage you to take notes. Physically writing something down does help you form memory. It does help you hold information down. Some of you have, are testing your registry soon. Some of you have already tested. You've already had a look at the thing. It's not incredibly difficult, but the test does tailor itself to you. So my first thing I want to do is motivate you tonight. So what is the root word of motivate? Motivate is motive. Why did you get into this? Why did you decide to come to an EMT or paramedic program? What was your causative factor? Well, mine was 9/11. I'm 32 years old now. At the time, I was in 6th grade when that happened. I remember wanting to do something about it. So years have gone by, and of course, I read Marvel comics, and I wanted to be the Incredible Hulk or something, or Spider-Man. But since I can't survive gamma radiation, and since I haven't found a radioactive spider to bite me, I've decided that I want to do something that mattered. So I appreciate you coming forth and saying I'm going to do something that matters. Can you imagine a day where you call 911 and nobody shows up? That day is coming. That day is coming. We don't have staffing. Grady's running double B trucks right now. Atlanta Fire just changed our model to where we used to have them do EMT-A and go to the field, and firefighter 2 and go to the field. Now they've changed it, EMT-B, firefighter 1, get on truck, bang, out. We've had to lower our standards just to meet staffing, because somebody showing up is still better than nobody showing up. Half of nothing will always be nothing. So something is better than nothing. So what we're looking at is, I'm gonna move that thing, I can't see. All up in my way. So we're taking a computer adaptive test. You have to understand the animal you're hunting. If I go hunting for a bear with a gun that will take out a squirrel, I'm not going to be very successful. I'm going to make it mad, it'll chase me. So I need to know what I'm hunting. The National Registry test is computer adaptive. It will tailor its questions to you. If you were sitting there getting super hard questions, you're probably kicking its butt. One of the guys in this last course actually retired as a PA, right? And he just took the National Registry and he smoked it. It was giving him EKG questions. You know why? Because he was answering the questions on a level that was way above the EMT-B or EMR or whatever. But it was giving him those hard questions. It's looking for a 6. If it's a scale of difficulty, it's going 1 to 10. Registry's looking for like a 6. And if you're getting level 9 and 10 questions that are beyond or way up here, you're doing a great job. Now, if you're getting like 30 airway questions, there might be a problem with your airway knowledge. So it's computer adaptive. It's 70 to 120 questions. There are going to be 10 beta questions, though. What do the beta questions do? They're pilot questions. They're for the test bank. They're to learn you. Within those 10 questions, it's already decided how it's going to formulate your test. It's already decided how it's going to send questions to you. And then the rest of it's graphing as it goes. What are you doing? It smells blood in the water. If it sees that you're weak on pediatrics, it's going to start machine gun firing you pediatric questions. You can't know it all. That's true. You can't know it all, but you can be as prepared as possible by preparing for every section adequately. This is not a master EMT-B or EMR test. This is minimal competency. Minimal competency. Most students that go and that have taken this thing and don't pass it the first time, it usually wasn't a knowledge problem. Usually, if you can go through an entire course, all that stuff is covered. It's usually a testing strategy problem. It's usually a problem with how you approach things. It's usually anxiety. One of our students who just crushed our course, that we just talking about outside, he should have went there and elbow dropped it and beat the hell out of it. But he failed it the first time. You know what it was? Anxiety. You know how I know? Even for the psychomotor, he was about to puke because he let his anxiety get over him. So if you want to smoke a doobie before you take it, I'm unofficially saying that's okay. So pilot questions, 10 questions, calculator. You got that on screen if you have to use it, like if you have to formulate a burn question. I'm terrible at math, but I got old Google in my pocket when I'm on scene with real patients. You know what I got on the screen for the National Registry? A calculator. A calculator. You have to know peds. 15% of every category is about pediatrics. We don't run enough pediatric calls to be supremely good at them. I've been a paramedic since I was 20 years old. I'm hitting my 13 years as a paramedic. And I've ran pediatric cardiac arrest, and I've done some, but even working in the city of Atlanta, I didn't have that many real sick kids. Kids are very resilient. So we have a weakness for this in EMS. Registry understands that, and they're going to send you pediatric questions in every section. If you're going to be good at anything, you need to be good at this ped stuff. So we have sections. So everybody mute your mics, please. Mute your mics. Thank you. So we have sections. We have airway respiration taking them 18 to 22%. Cardiology and resuscitation 20 to 24. Trauma is 14 to 18. Medical ops is 27 to 31. Operations. EMS operations is how you work in and around an ambulance. Certain procedures that are supposed to happen in a certain order is operations, an operating order. Why is it important? If you do D before you do A, that can cause patient death. Let's talk about primary assessment. If I get there and the patient's bleeding to death, but you ignore that and just start, checking their airway, does it matter if the airway is open and patent if there's no blood in the body? No. How long can you go without oxygen? 3 to 6 minutes, and then you'll start to suffer some brain damage. 7 to 8 minutes, you've lost some brain cells. 10 minutes, yeah, you got your brain dead, kind of. You know how long you can last with a femoral artery bleed? 2 minutes, maybe. So that's why we say general impression, life threats first. That way we can address any life threats or gross bleeding immediately. There's an order of operation that has to happen. Your operations section will address that. Same thing if we're working a mass casualty incident. One of the first things I have to do, of course, is scene safety. If you remember me from the course, one of the things I would say was lanulations 1-9 or gradulations 1-9. If the scene's unsafe, thou shalt dip without. So that's
how was that during the last year they were getting rid of the location, and we were supposed to. It was just so much drama, and
mute your mics, please.
I felt like I was there for my ex a lot more than.
Let me hear. Thank you. What was I saying? No. Oh yeah, lanulations. Amen. So medical terminology. I can promise you that they're not going to give you easy one-liners. They're not going to say the patient's having difficulty breathing. The patient's having dyspnea. You must know medical terminology to pass this test. It has to be strong. Now, you've heard some of me say that communication is key, but comprehension is the real key. If I'm on scene saying the patient's got a lacerated rectus femoris, vastus lateralis, and vastus medius, most of you won't know what I'm talking about. But if I say his thigh is cut from here to here, involving 3 muscle groups, you would know what I'm talking about. Comprehension is really key on a scene, but the registry is not going to ask you about things like that. They're going to use the more complicated word, dyspnea. Or one of my students told me about a question he had. It was asking about sildenafil. The other name for that is Viagra, but if you hadn't known that, he'd have been up the creek without a paddle. So your medical terminology has to be strong. You have to know what prefixes are, root words, and suffixes. You know why? Because every 2 years, I retake the Paramedic National Registry to keep my National Registry license. And every time I do it, even though I teach medical terminology at a college, let me repeat that, I teach medical terminology at a college. There are still words I don't know.
Because I don't want to can't let me start a new trend, you know? But yeah, I get it. I work 3 jobs. I work 7 days a week from certified free. But like, you know what I'm saying?
I'm saying?
So there's words on there I don't know, but you know what I can do? I know what the prefix is. I kind of know what the suffix is. I can figure it out. It's an ABCD multiple choice exam. You can figure it out if you know enough prefixes, suffixes, and root words. And then when you get out of there, first thing I do is like Google, I'm like, I was right. Yeah. Gotcha. So my advice, one of the things I would definitely focus my energy on is medical terminology. Besides medical terminology, you know what's one of the biggest problems that people have passing the registry is? Comprehension. Reading comprehension. Not that you can't read good, but you're not actually understanding what they're really asking you. Because you miss a word like except or but. Every word matters. And orange is a fruit or a color. What you think?
Both.
True. But which one's more right? And is possessive. We're talking about a fruit. Every word matters. Not to pick on you, but that was a trick question. So there's a dump sheet opportunity. You get a blank sheet of paper for your cognitive. This is an example of what one of your dump sheets could look like. On that dump sheet, you can write whatever you want. You can place on there formulas or other things to help you with the test. Now, me personally, this helps some students. Personally, though, if I can remember enough to put on a sheet of paper, I don't really need the dump sheet. But if it helps you, it helps you. Some people are more visual. They can put it down and look at it. It'll help them once they start the test. Anxiety will increase a bit, right? Just a smidge. And they may not remember it during the test, but if they wrote it down when they first sit, they might can handle it. So testing strategy. This is probably the most important section we cover. Every one of you has already been through a course. Every one of you has already been through a class. So the information should be here, should be there. This should be just a little review for you. My first piece of advice is get a test prep app, not a free one. If you're not paying for it, it's not worth a crap. I'm not trying to get you to spend money because I'm not affiliated with any of them. But I can tell you that you really do get what you pay for. It wasn't really a fair experiment, but I can tell you that in a past course, the students who got the free app and the students who paid for it, the ones that passed were who? The ones that paid for it. So the three that I'll hail as being pretty good. Medic tests. I didn't believe them at first, but 2 groups of classes have now told me they've had questions on the registry, word for word. Miss Clark that just passed, word for word, she said. Some of the questions were word for word. Medictests.com, masteryourmedics.com, or EMT.national testing are the 3 that I'm going to promote to you. Again, I get nothing for saying that, but if it works, right? Spending time on those things. You have to change your spatial time. Instead of being in the truck, flipping on Facebook, on the gram, sending pics to somebody, you need to be working, using that freehand time to prepare. This has to become your magnificent obsession for the next couple of weeks, or you won't be successful. I'll admit something to you. A couple of years ago, I'd been a medic for like 7 or 8 years, and I was also at the time already a critical care and flight medic. So here it was time for me to recertify, and I was like, you know what, I'm gonna go in there and crush this thing. I went and retook the Paramedic National Registry to keep my license, and I failed it. You know why? Because I didn't prepare for it. I was already a paramedic, already an instructor, already critical care and flight medic certified. And because I didn't prepare myself, I failed it. Now, of course, this lit a fire under me. So I spent a couple weeks preparing. I go in there and I finish it in 70 questions and in 27 minutes. So I went back with vengeance. But even if I go retake that thing to keep my license, I've learned I have to take some time to prepare. I cannot stand admitting when I made a mistake or looking weak, but I want my mistake to be something you learn from. That is what wisdom is. Experience is, I experienced it. I touched the stove. Wisdom is, you watched me touch the stove. Please take this seriously. I was already a paramedic. It can still get you just based on not being prepared. So fill your spatial time. Read every question twice. Make sure you know exactly what they're asking before you try and answer it. Now, I will say this, you ain't got all the time in the world. You can time out and fail. If you time out, you fail automatically. If you time out, you fail automatically. So please be cognitive of your time. Read every question twice though. But there's going to be some questions that are simple recall questions. A recall question is, how many bones are in the body? 206. That is a fact. It does not change. There's no scenario for me to figure out. It's cut and dry. Those questions will save your butt. They were like, oh, I got that, bang. I bought time back. The 3 minutes I spent on that scenario question, I just got it back by spending 10 seconds on this one. Read it twice, followed my rules, 206. That's a no-brainer. Those are the ones that you're looking to get to buy time back. Another thing is there's going to be 4 answers. 2 of them are going to be super dead wrong. 2 of them will be super close. Then you have to differentiate between the right and wrong answers. The most right versus the more wrong, like the orange. Is an orange a fruit or a color? Again, and is possessive, so it will be a fruit. Those little words, those tidbits, every one of them could make a difference and matter. Now, personally, I don't really think that the National Registry test is a full, real way to see if anybody's going to be a competent EMT or paramedic. I personally think it's a money scheme. However, we don't have anything better as of now. But if I could spend the time I spend getting ready for the national test, just by preparing you for being a Georgia medic and how to operate within our protocols, I think you'd be a better medic and for the time we have. That's just how I feel. So most of the questions are scenario based. And again, those words matter. Terms like you should or but or anything that could change what the treatment is, you have to find and use to your advantage. We're also going to be looking for signs of criticality. Criticality. Your airway questions are big about this. Finding out which gun to shoot or which trigger to pull, such as, do I need to give this patient a cannula, non-rebreather, or do I need to bag for them? I'll give an example. Patient's breathing 3 times a minute, shallow respirations. That should have triggered all of you, been like, bag them, BVM, bang. Pale, cool, clammy, you're thinking shock. We're trying to trigger you to do a response. I want an appropriate response. Registry is looking for the same thing. Now, some of these scenarios are more nuanced than that, meaning they're more subtle, sneaky. You sneaky bastards.
I saw a test question yesterday when I was doing a practice test. It was like this person was prescribed like hydrocodone after a recent surgery, has pinpoint pupils, shallow breathing, and is like partially conscious. And the questions were like 2 obvious answers were give them Narcan or bag them. And I was like, oh, there's obviously an overdose. Narcan. Nope.
Bag them.
Bag them first and then give them Narcan.
So that's true. Super close, right? Both of them are the right answers, but order of operations matter. While I'm drawing up the Narcan, I could be bagging them and getting that O2 sat back and putting some circulating oxygen in their body. That's a good answer. So you need to read the question, read it well, read it twice, but don't read into it. Some of you I know are overthinkers. Some of you I know will overthink a question and go way farther than you need to go. The bad thing about a psychomotor test is there's things that the streets can tell me. I can smell blood. I step on a broken needle. Oh, he probably did overdose. He's not breathing, he's got pinpoint pupils, blah, blah, blah. There's a bunch of needles I just stepped on. The streets can tell me things, the environment can tell me things, the scene can tell me things. You take a psychomotor test, you're listening to this guy and he may forget to tell you something, you know what I'm saying? So you can't get a lot from that. That's the negative thing about a psychomotor. You're taking a written, you know the good thing about a written test? They can only and will only test you over what is written there. What does that mean? The scenario is not going to go any further. Steve, will you let him in for me? Thanks. A scenario will not go any further than what is written down. If it's written, then it happened. That don't mean that, well, if I do this, it'll make you bleed out and do this, this, this. No. If it's not written there, it didn't happen. Don't assume their blood pressure. Don't assume anything. Answer the question based on what is written there. Do not overthink. Also, do not second guess yourself and change your answer. Some of you have done that, will do that. Overthinking, second guessing, and you need to go with your first answer. Your first instinct is right. There's something subliminally about that is causing you to pick that. And I can promise you the same thing will happen when you're actually working the streets. I have heard my instructor's voice in my head even 13 years later. Don't do that, they'll die. Okay. So listen to your gut. Here's another trick. Read the last line of the question first. Find the question mark and you find the actual question. Find the question mark and then read that first. Read the last line first and then read the answers. What does that do for you? It lets me know exactly what they're asking. So as I go through the scenario, I know it's going to be one of these 4 that I've already read. It already prepares my mind to have an idea of what they're asking for. That way, I can't go way left field with this. Why? Because I already know that they're going to ask one of these 4 to be the answer, right? Does that make sense to everybody? Cool. Next, keep it simple. I learned that from the fire department in Sumter County, Georgia, back in like 2008. Keep it simple, stupid. Kiss it. What does that mean? The test ain't really trying to trick you. There's no end all be all game here. They're just trying to see, will you kill someone or not? If I didn't feel that my EMTs or paramedics were safe enough to work on the streets, I wouldn't release you. I wouldn't sign your paperwork. The test is the great equalizer, though. This EMT test right here, it's trying to see, are you going to hurt somebody? And that's the main thing we want to avoid, because the first rule of medicine is to do no harm. We don't want you to hurt anybody. We want you to go out there and help and do a great job. But we have to see, do you have the mental capacity to perform as a minimal competency EMT? They're not trying to trick you. So again, you build one house, one brick at a time. One brick at a time. How do you eat elephants? You eat an elephant one bite at a time. This test is not a 70 to 120 question test. It is a 1 question test that you take 70 to 120 times. Every question needs to be treated like it's the one that will make you an EMT, EMR, paramedic, or whatever you're trying to do. Why? Because it actually could be that one that sets you over the edge. So it is a 1 question test. You're taking 70 to 120 times. And again, there are 10 pilot questions that don't matter. They don't do nothing. They're beta questions. Damn them, right? But those 10 pilot questions are going to decide the direction your test goes. And the National Registry can usually predict within a 92% accuracy whether you'll pass or fail based on the first 10 to 20 questions. It's that good. I wish we had software that could match it so we could prepare you better for it, but nobody's come up with anything yet. So your head has to be in the right place. You can have all the knowledge in the world, but if you don't use it in the right way, it will not make a difference. It will not make a difference. Your head has to be in the right spot. If your anxiety is crippling, it will cause you to not be effective. You can know the answer, but can't think of it at the time. So it has to be a pressure test because this is a pressure job. I've told my students that we train you with the 3 a.m. rule. I have to train you to the point to where at 3 a.m., you've been awake for 24 hours already, ran 50 calls. At 3 a.m., this pediatric sick kid comes out. I don't need you thinking about it. I need you to know it by muscle memory. We do not rise to the level of our expectations. We will fall to our level of training. That training will kick in. That muscle memory will kick in. This is a pressure test. It has to be hard. We can't just let anybody run and gun as an EMT or a paramedic or an EMR. You're going to have lives in your hand. Even if you work for a transport service, there's going to be opportunity and times and chances that somebody's life could be on the line. I would say even so, if you work for a transport service that mainly doesn't do emergency, you should be more prepared for an emergency, because when it happens, and it will happen, you have to be ready for it. When that wolf's at the door, are you going to have a loaded gun or not? Are you going to keep your skills sharp or not? That is up to you.
There was a transport just this afternoon, lady went into respiratory arrest.
Can it happen?
Super easy everyday transport and she almost died.
I was doing my third life, so she's working on seizure before putting on the bags.
So you're making my point for me. I like it. Thank you. That's a fact, isn't it? You have to be ready. Even working for a transport service, you're going to have lives in your hand. But here's the good news. You have worked your butt off. You have studied. You've sat through hours of lecture. You've earned the right to sit here. You've passed the course. You've earned the right to sit for this test. So own that fact. Own it. Don't go in there wishing for some easy little test. I would go in there and want to be challenged. See if I'm right for the job. See if I can actually handle this business, this line of work. Go in there and make this happen. Make your instructors proud. Make yourself proud. You're going to be a part of a new type of camaraderie and brotherhood that, you didn't see before. And we need you bad. Like I said, we're almost to the time where you call 911 and nobody shows up. We don't have the people. So I'm personally grateful for you stepping up and saying, I'll answer that call, because this job ain't for everybody. It is not for everybody. The night before, stop studying. It will do you no good to cram at this point. Either you know it or you don't. Smoke a doobie, have a drink, play some Xbox or something. Relax. You need to be relaxed. You've done the time. Well, some of you, I'm sure. Some of you didn't. I don't know. I don't know what your study habits are, but most of you, I'm sure, did the time. You studied, you put the work in, and hard work does pay off. So the night before, just relax. Spend time with your family. The day of, you need a good breakfast. Good breakfast that fuels you, not fuels your cravings, fuels you. And maybe even just a 30-minute walk. There are university studies that show that a little bit of physical activity can actually cause more blood flow to go to the brain. Also being very hydrated. Through hydration and Monster, everything is possible. Monster energy drink. It's all possible. But you need to be hydrated. You need to have a good breakfast. Do a 30-minute walk. Do nothing the night before. This is ways you can prepare. And this isn't me just up here whistling Dixie either. All of this you can Google and find out that university studies have been done on this. And just about any other test prep app or registry refresher or whatever you call this thing, most of them will agree to the letter of what I'm telling you. Remember, there's two ways to get a question right. One is to know the answer. The other one is to know that the other three are not the right answer. I may not know exactly this is the right answer, but I know these other three cannot be it. The process of elimination is a real thing. You can be a really good test taker and take a test over crap you don't even know and still do well. There is that chance, in fact. So for the sake of time, I'm not going to spend any time on A&P. I'm going to get directly to patient treatment. But I would say that medical terminology in your A&P needs to be strong. Why? A&P and medical terminology are the basis of this type of program. This test is based on it. But we're going to be very pressed for time tonight. So with that, I'll tell you to make sure that you get a copy of this PowerPoint, go over your A&P stuff, and make sure that that stuff is strong. So I'm going to move through that and get to actual patient assessment. So you have to know what these terms mean. One, so you can be in a systematic, methodical order of treatment. Two, so you can actually understand that the patients in these questions are following this modality. It is very important to be systematic. That way you don't miss anything in real life and on this test. The systematic approach means you're going head to toe, A, B, C, D, E. That means I'm catching all of these things as I go through this patient assessment. That's how you don't miss things with people, that thorough approach. You might be tempted by the easy button and be like, you know what? It's probably just this. But I 12 lead everybody. You know why? That's how I find the little old lady that was just feeling, well, I feel weak today, baby. And there she is weak because her heart's not working very well because she has a STEMI going on. I check blood sugars on everybody. I still do a physical head to toe assessment on everybody. That way I don't miss anything. You might have done some third eyes now and seen people skip steps. I don't skip steps, and I encourage you not to skip any steps either. Don't skip steps with your patients. Do a full history on them using sample, allergies, past medical history, last oral intake. This is information you'll need. But also you need to know this for your registry. Knowing what OPQRST is and AVPU is going to be very vitally important to you. Your primary assessment will be done on every patient you do. Every patient you've seen. For that scene size up, the scene size up is not a one-time thing. It is a multiple thing. Done several times. Why? Because the scene changes, and it can change like that. It was safe, now it is not. So if it becomes unsafe, remember Regulations 1:9. The scene's unsafe, thou shalt dip it out. ABCs. The ABCs. Let's talk about them. Let's take a quick break and then we'll get back to the ABCs. How about that? All right, we're back at it. Recording, let's do it. So we're talking about scene size up and being safe. We want to be safe. We want to get it in. Now, the ABCs are important. Patient has a pulse and shows signs. Life set in this order. If they got signs of life from the pulse, if they got a sign of life, go ahead and do ABC. But if there's no pulse, what's the point, right? So we switch to CAV. Circulation is more important at that point. What was the example I gave earlier? If I get there, they're bleeding out, you can die from a femoral bleed in a minute 30, 2 minutes. You can go 4 to 6 minutes without air. There is an order of importance, operations wise, systematic order that we don't deviate from unless you got a real good reason. But for the National Registry test, do not deviate. ABC, 1, 2, 3. Keep it simple. Kiss it. Keep it simple. Why is this thing not clicking? Who broke my stuff? All right. So some signs you need to work for are those signs of criticality. Airway, is it open? Is it patent? What does patent mean? It means is it going to work? Is there some type of blockage? There are sounds that the upper airway will be making. Snoring is indicating a tongue in the way. That's the most common airway obstruction. The tongue is in the way. You can fix that with a simple head tilt chin lift. If there's no trauma, if there is trauma, we're looking at a jaw thrust. Don't be surprised if they throw some kind of simple, nuanced question at you like that, expecting you to know the difference.
I do have a question. Apnea. What is like an example of apnea? Because I've seen that on the test, and I got confused between apnea. I got apnea confused between cardiac arrest and apnea.
Very good. So cardiac arrest means the heart's not beating and there is no respiration. Apnea, A meaning without, nia meaning breathing. So it just means that their heart's still beating, but that they're not breathing. So eventually they will break down due to hypoxia and then they will go into full cardiac arrest. You have a patient in apnea, you have a big decision to make to go ahead and head that off and start some airway management protocols to keep them from going into cardiac arrest.
Okay.
Make sense?
Right. So clarification. So they're apnea. I mean, they're breathing, but not.
They're not breathing at all.
They're not breathing
At all. So we need to bag them. We need to get BVM on there. Ventilation is what? Moving air in and out. There's a difference in oxygenation and ventilation. If I put a nasal cannula on Isaiah here, I'm gonna give him some oxygen. It's good. But I'm not actually moving air in and out of his body. That's done with a BVM, that bag valve mask. Does that make sense? Right. So that's how we treat an apneic patient. There is a time and a place to bag somebody that's still breathing too. We used to say below 8, ventilate. But if we got somebody with shallow breathing or inadequate respirations, we do want to be able to meet that need and help them breathe until we can figure out what kind of cause is making them breathe that slow. Is it a narcotic? Is it a neurological deficit? Some type of cognitive disconnect? This is what we're looking at. Sometimes we can't figure it out in the field. We don't have the diagnostic tools and or equipment. But I can see he's breathing 2 times a minute. Probably need to get him up to 10 or 12. Make sense, everybody? I like it. So breathing, is it good enough? Oh, I'm going back to airway. So we have the snoring being a tongue in the way. We have gurgling, meaning there's fluid down there. Is it blood? Is it spit? Is it vomit? All I know is that it's a fluid that could become an aspiration risk. What is that? When that fluid goes into the lower airway from the upper airway, it could clog up some alveoli and get in the way of gas exchange. Everybody understand where I'm at with that? The alveoli are responsible for gas exchange, for actual breathing, for oxygen getting onto red blood cells and being transported around. If there's fluid down there, it will stop that from happening. So you need to be able to suction that out. As an EMT, you can do that. EMR, I'm not sure. Nope, just making sure. So some of this will apply to EMT mostly, but the EMR, you too. Stay within your scope. So another sound we can have is called stridor, high-pitched whistling or crowing noise that's indicating a partial airway obstruction. It could be stridor caused by somebody swallowed a quarter. It could be stridor caused by the airway swelling closed by breathing in hot, smoky air from a burning house fire. It can be stridor caused by you getting stung by a bee and that tissue becomes full of edema and closes up. Stridor means partial airway obstruction. If it was fully closed off, you wouldn't hear anything because there's nothing to hear. No air movement is happening. That's the upper airway. Now breathing. Are they breathing good enough? What is their rate, their rhythm, and the pattern of their breathing? Rate is important. 12 to 20 is my normal adult breathing, right? That's what that is. So if they're above 20, they're called tachypnic, tachypnea. That means they're breathing too fast. Is it anxiety? Is it an asthma attack? Are they having a symptom called air hunger? Are they trying to suck in more air because they're slightly hypoxic? Again, sometimes it might just be, I'm just excited to see you. I called 911, I just got in a wreck. I'm a little freaked out. It happens. Or they're breathing too slow, below 12, 11, 8, 7, 6. Why are they breathing so slow? Is there something impairing them physically, mechanically? Is there an obstruction in their chest? Have they lost the ability based on chemicals they've ingested? We can fix some of that. But if not, I can always bag you and breathe for you. Does that make sense? So I need to know the rate, the rhythm, the quality of the breathing. Lower airway sounds include what? Wheezing, rhonchi, rales, pleural friction rubs. I gotta be honest with you. Once you're in the field, if you ain't got a good stethoscope, you ain't gonna hear nothing. Working in Atlanta, you think I heard much if I had a cheap stethoscope? No. There's cars going by, people are screaming. It's hard to hear if you got a cheap stethoscope. So if anybody got you a graduation gift, please make sure it's a good stethoscope. I'm somebody, if you need to hear a cricket fart from 3 miles away, stethoscope. Good stethoscope. Don't let nobody buy you no Raptor. The Raptor shears, and they're just for looks. Shears are shears. Get you a good stethoscope. You need to be able to assess breathing. So what else? Altered mental status, shallow respirations, respirations over 30 or under 10. That's when you need to have an action plan. When I say shallow breathing, you should be thinking, I need to bag them. If I have a patient breathing under 10, I'm thinking I may need to bag them or find out why they're breathing 10 times a minute. Over 30, you could still bag them if they'll tolerate it. You could still bag them if they'll tolerate it. Now, circulation, the first thing you need to ask is, do they got a pulse? That's important, right? That changes what I'm doing. It's ABC until there's no pulse, then it comes CAB. Because it doesn't matter if I'm bagging them, right, if they have no pulse. It's important to have a pulse. So check that first. Next, I need to know the rate, rhythm, quality of that pulse, and then the skin color, temperature, moisture. What will that tell me? Rate, rhythm, quality. The rate tells me how fast is it. 60 to 100 is a normal adult pulse rate. If it's below 60, either they're a supremely in shape athlete like me. Thank you. If I said anything, great. Or they have some type of bradycardic issue causing that. Some type of reason for their heart to be so slow. Now, if they're over 100, there's some reason for that heart to be over 100. The body might be stressed, could be anxiety, could be a form of shock showing itself with a symptom. We got to understand why. What will the skin tell me? Pale, cool, clammy, you're thinking shock. The body is shunting blood from the periphery to the vital organs. That's one of the first kind of compensatory mechanisms that will exhibit itself of shock. Pale, cool, clammy skin. And Registry is going to put this ball on the tee for you and make it easy. Patient has pale, cool, clammy skin. It's not trying to trick you. Contrary to popular belief, my co-instructor for this course is a registry rep. Literally has wrote questions for the registry. Literally has wrote the book on this stuff. They're not trying to trick you. They just don't want you to go out there and kill someone, but that's bad, right? Drugs are bad, okay? No, let's not do that. So we made it through the patient assessment section. We've made it through testing strategy. You have to have a strategy. You have to stick to it. You have to have a mode of operations. You have to stick to the plan. You also need to take some extreme ownership of this. This is that time we talked about where we burn the ships. What does that burn the ships mean? It means that I give myself no way of escape, no way back. The conquistadors, they came to the new land. They saw they were vastly outnumbered, right? And they're like, their butts whooped. The commander went and was like, hey, burn the ships. As the ships burned, he's like, y'all ain't got no way home. Gotta fight. They fought and won. This is your burn the ships moments now. You need to be all full steam ahead. Put down Facebook, put down Snapchat, quit sending pics, John. All them girls you with. Stop all that and focus on this. Get you a test prep app, medic test, EMT.national testing, master your medics, and spend hours on it per day. People will always make time for the things they really want to do. You know how much of your day a 1 hour workout is? It's 4% of your day. If you spend at least an hour studying every day, that's only 4% of your day. You spend 15 days studying, you've done 15 hours of prep for this. Again, you should only need review at this point. Taking those little National Registry test prep app tests, they're not punitive. They're not nothing against you, but it shows you where the chinks in your armor are at so you can fill them. You know what? This thing says I'm pretty weak on respiratory. I should probably spend some time on it and strengthen that area of myself. So ventilation is movement of air in and out. Diffusion is that part of gas exchange. What does that mean? Gas exchange. I breathe in oxygen, I blow out CO2. I exchange gases through the pulmonary capillary bed and now alveoli. Capillary bed has net filtering. It keeps the nitrogen and all the other aspects out, allows the oxygen to attach to hemoglobin in my bloodstream. Crackles, rhonchi, stridor. These are all airway sounds you need to be familiar with. They tell you different things. Stridor, of course, is that partial airway obstruction. Wheezing is that high-pitched, coarse whistling in the lower airways, indicating possible asthma or bronchospasm. Oxygenation is different. Oxygenation is not ventilation.
Oxygenation is ventilation is
BVM. You can keep it simple like that if you want. There's a difference in the two though. And then cellular respiration is a whole different ballgame. To keep it simple, the cells need water, oxygen, and glucose to create energy for your body. They don't have the oxygen, they will create acid instead. Make sense? They have to have this component. Your job as an EMT or an EMR is to make sure these patients have what they need to maintain homeostasis. So I'm not going to get deep into the physiology. Again, you need to be strong on AMP and your physiology is going to be point, but we're already rushed. I am actually thinking we may not even finish tonight. But I'm going to get as far as I can. So that means I'm going to, again, just try lecture style. And I'm also going to try and go over the things that I know are going to be on the test. The rest you need to commit to memory. Medical terminology, anatomy, physiology, pathophysiology. You need to make sure you're putting that in your own time while you're in your study time. So opening the airway, we talked about the head tilt, chin lift. We talked about modified jaw thrust. Won't beat that to death. Upper airway anatomy. We talked about that. So a lot of this is just the AMP portions that are important, but I don't have time to go over. Airway abjuncts, I do have time and need to go over with you. So the OPA, the NPA, the nasal cannulas, the nebulizer masks, and if you have a jump drive with you tonight, you can take this PowerPoint with you. I made it for my EMT class. It's just a Registry PowerPoint. You're welcome to it. I'd email it to you, but it's bigger than hell, so it's not gonna send. I done tried. But you can get a copy if you've got either a computer with you, a jump drive, or something. I would love to make it available to you. I want you to pass. So we're talking about the OPA. What do we use that for? To keep, there it is. They're unconscious. Their airway needs to remain open. That tongue will keep flopping back unless I have something down there physically holding it from doing so. But I don't want to gag anybody. If I put this in their throat and they gag, I need to pull it out. Why?
You don't monitor that, right?
You don't have to,
I don't want them to vomit. I don't want them to vomit. I also don't want them to break it down. When you engage the gag reflex, the vagus nerve is triggered, releases acetylcholine, and will slow the heart rate down. It could slow it down to very unsafe levels.
So
What you got?
with opening up, so you're supposed to wiggle, put your fingers, like finger to the eyes.
So you can check,
To make sure they don't have a gag reflex or something like that.
you can tickle their eyelashes, and if they blink or move or something, it usually is supposed to indicate that they don't have it, they do have a gag or don't have a gag. In the old days, we just was like, God, yes, he's got a gag. Nowadays, we have sophisticated, tickle their eyelashes, engage that cranial nerve. Science. So the nasopharyngeal airway, that's my plan B. Okay. So that plan B is, they've got a gag, but I still need to keep that airway open. I can put the NPA in there. Only time I wouldn't do that is if they have a Lafort fracture across their face right here. If this is cracked, I don't want to put anything there. Contraindicated. Nasal cannula is a good small dose thing, give you a couple liters of oxygen. Nebulizer is a great thing to nebulize medication. Yeah.
so what if they have a gag reflex and the thing right
Heaven waits for me.
there? They gone?
You can still try and bag them. If you have a paramedic on scene, they might sedate them and take their airway from them and just put a tube down there. We have workarounds, but not at the EMT or EMR level. No.
You said not EMT.
What am I nebulizing? I'm nebulizing drugs to bronchodilate the lungs. What do I want to do that for?
If someone has wheezing or something like that.
So if they're wheezing, if those lower airways are squishing down tight, they're closing off and closing off, eventually they will close shut. I hit them with that nebulizer with that medication, boom, they're wide open again. It relaxes them and opens them up. The non-rebreather mask, it's kind of a big gun. You can up their oxygen concentration to 80 to 100%. The ambient air we're breathing right now is 20.84% oxygen. Everybody just says 21 to make it simple and round up, but it is 20.84. But you can say 21. The rest of it is nitrogen, thick, dense gas that we cannot perform gas exchange with. But that thick, dense gas does help keep the lungs open. It's thick, it's dense, it just sits down there like, I'm gonna hold these walls from closing together. The alveoli will try and squish together and form what is called atelectasis, which is collapsed alveoli. It will not allow it to happen because of the thick, dense gas. Surfactant, which is a phospholipid compound, keeping the lungs open. And of course, again, the air we're breathing right now is 21% oxygen. With this non-rebreather, you can crank the concentration of oxygen in up to 80 to 100%. So to give you an example, if I was to make some sweet tea, I put 1 cup of sugar in it. All right, that's like KFC sweet tea, kind of sweet, but not super sweet. Then I put 5 more scoops of sugar in there. Now, we at McDonald's, the concentration has changed, right? Now if I put 2 more, 7, 8 scoops of sugar, you got my grandma's sweet tea. I don't know why she was diabetic. Couldn't figure it out. So it is important. Concentration matters. How much of it's in there? You can up their oxygen concentration with a non-rebreather. The BVM, the bag valve mask. I'm gonna tell you right now, I ain't put my lips on none of you. You'll sit here and just die. I did it for a baby once. He puked on me. He lived though. That's why I just make it like this. I ain't
My
doing it.
lips go on my hands.
I ain't doing it. You don't know what people got nowadays. Might have herpes on the lip or something. I ain't doing it. You ain't gotta do it no more.
You got gloves on though.
I ain't doing it. Matter of fact, that's what EMTs are for. That's why I'm a paramedic and get my EMT to, don't do it. Kiss him. Put your mouth on it. You ain't gotta do all that now. We have the BVM. You form a seal over their face, C&E, and you can squeeze and ventilate air into them. You don't have to put yourself at risk for a communicable disease. Respiratory things like the Rona, tuberculosis, all types of things can be passed that way. Again, you can get lip herpes, so don't do it. Keep your lips to yourself. Use the BVM. Now, when I squeeze a BVM, am I trying to pop their lungs?
Yes.
No, we don't want to pop their lungs.
I mean, that first observable chest rise.
I'm just wanting observable chest rise. How easy would it be to pop the lungs like that? That bag is capable of about 15 to 1600 mLs of bag power. You know how much the average adult breathes in? About 500 mLs of air. That thing can give 1500. That's a lung popper, especially if you've got an overzealous recruit or a new EMT, like, I'll save him. Stop it. Don't. Count to 6, then squeeze. Let the chest rise, then quit. It's that simple. That just says everything I just said. We're gonna move on. So specific respiratory diseases and problems we're gonna run into in the EMT, EMR level. COPD, chronic obstructive pulmonary disease, asthma, congestive heart failure, pneumonia, a pulmonary embolism, and pneumothorax. At the level of the EMT-B, you are in, or EMR, whatever you're doing, you do have limitations to what you can do. What you got, buddy?
What is, do you have a disease person?
Okay.
But, that's after you finish.
Okay, I like it. So there is a certain limit to what you can do at your level, but good oxygenation, airway management, and bagging it's still better than nothing. There are some of these things that are better suited for a paramedic to do, but again, you are better than nothing. Right now, Grady, we're sending double B trucks to patients. There's a shortage. Still better than nothing. I get there and he's not breathing. EMT-B can fix that. He can bag them until the paramedic can get there and then intubate them. You still have a role to play. And anybody that is anywhere in life, they started from nothing. Every one of us that's a paramedic and does all this other cool stuff, electrophysiology, we started as EMTs. We started right where you're at. You don't have to be great to start, but you have to start to be great. Isn't that right, John?
That's right.
So COPD, we've got blue bloater, pink puffer. Emphysema in a nutshell is baggy lungs. The lungs are baggy. They've lost elasticity. They cannot squish all of that air out. So they have what's called chronic CO2 retention and air trapping. This is their main problem. They cannot get air out. They usually have pursed lips, like they're trying to kiss somebody. That pursed lip breathing is putting back pressure into their lungs to keep their alveoli open. Pursed lip breathing keeps their alveoli open. And they don't even know they're doing it on purpose. It's just a compensatory mechanism that they're doing. Blue bloaters are usually fat, overweight. They have lots of mucus and chronic inflammation. Let's talk about the term chronic bronchitis. Chronic meaning it's all the time happening. Acute would mean it just happened this one time kind of quickly. Bronchitis, let's break the word down. Bronchi, the bronchioles in their lungs, itis meaning inflammation. They have chronic, all the time inflammation of their bronchioles. Chronically bronchitis. So how do we treat that at the EMT-B level? Well, you have the option to do what? You can give them some of their meter dose inhaler that give them some albuterol. You can set up the albuterol for your paramedic. I'm not exactly sure if y'all can give it like off the rip.
Like I said, it was been based on the provider.
Based on the provider and the protocols that they are working under, if that makes sense. So most of this is going to be caused by what? Smoking. Smoking damaging those lower airways, paralyzing cilia, inhibiting your ability to get debris out. Your trachea and lungs are coated with little hair-like fibers called cilia. And your goblet cells are producing mucus, which will cause what? The mucus traps debris. Ah, gotcha. And then you will cough them out. That's how that's supposed to work. These guys that are smoking, if you go smoke one cigarette right now, you're gonna paralyze your cilia for 10 minutes. Over time, you damage them. Now you're gonna develop COPD and all these other type of problems. So chronic bronchitis people are usually fat. Pink puffer's got the barrel chest and they got the pursed lips. What about a pulmonary embolism? What you got, buddy?
The question for that, so, what disease causes, for that one? So what disease causes production of mucus?
Blue bloater, chronic bronchitis. Overproduction of mucus and chronically inflamed, that's gonna be their problem. The pipe is full of fluid and they're always hacking up, right? You ever met somebody with COPD and they're always hacking junk up to different colors, kind of gross? So it's gonna be too much mucus, that's gonna narrow the pipe because there's fluid in here now. That make sense? Chronic bronchitis, the blue bloater. Chronic bronchitis. Did that fix it or you still confused?
Because it wasn't on the registry, that answer wasn't on the registry.
Okay. What was the other answer?
That was,
Epiglottitis.
there you go, that was one of those, asthma was another C word.
So asthma is a disease of three problems. It is an obstructive airway disease, just like these guys, but it's a problem with inflammation. It's a problem with mucus production, and it's also a problem with bronchoconstriction. It's usually triggered almost the same way a allergic reaction is. Here in the Atlanta area, the wintertime is a big asthma season for us. People turning on their heat for the first time, it starts cooking dust, bang, asthma attack. Or it's real cold out and the cold air they breathe in, bang, asthma attack. They get around some cigarette smoke, triggers them, bang, asthma attack. That makes sense? So it could have been either one of those three if you just asked them about a chronic obstructive airway disease. When we talk about COPD though, we're talking about blue bloater, chronic bronchitis, or pink puffer, which is your emphysema patient. Everybody cleared up? So pulmonary embolism. In a nutshell, there's a clot that is blocking blood flow to the lungs. This will cause a VQ mismatch, a perfusion to ventilation mismatch. Air is coming in great, but it's not getting oxygen attached to it. It's blocking blood flow to the lungs. Patient could die from this. And God bless the thing you can do about it. Get them to a hospital. Run quickly. You can support their ABCs. This is supportive care. Identify and rapid transport. I got it bolded here. You see that? Identify and rapidly get on. So that's all you can do for that. Where does it come from though? Usually a PE is from a clot formed elsewhere and it travels there. A thrombus forms where it's at. It builds a house. It stays there. But a pulmonary embolism or an embolism at all is a traveler. Embolisms embark. Embolisms embark on journeys. Usually it's the result of a clot formed in the legs from a deep vein thrombosis or a DVT. Let's say grandma goes on a 12-hour flight. She don't get up for 12 hours. She finally stands up when it's time to get out. Stands up, what breaks apart and travels to the lungs? Clot. Now she's got a PE. Atlanta Fire Rescue, Hartsville Jackson Airport Division runs the most PEs I've ever seen for that exact reason.
Biggest airport in the world.
Yeah, they make it. Asthma, we've already talked about being a disease of three problems: inflammation, bronchoconstriction, and mucus production. At the paramedic level, I've got an answer for all three. I can give them drugs to bronchodilate. I can also give them a steroid to treat inflammation, and I can also do what else? I can give them mucokinetic. I can intubate, you're right. I don't want to get that far down there if I ain't got to. A mucokinetic is a drug like ipratropium bromide, will actually move fluid out of the lower airway, help them hack it up. Is it time? Yeah. All right, you are excused, sir. Hurry back now, you hear?
I'll be back.
Plus 10 on your next quiz.
I'm gonna go help.
So the difference in asthma and status asthmaticus. Asthma is, of course, that disease where they're having an acute problem. You can hear the wheezing across the room. They're having some trouble breathing. I used to hate when medics would come up to the patient like, "Sir, what's your medical history?" I fix his breathing, then worry about documentation. Fix his breathing first. Then you can worry about your documentation. So if you get there and the patient's having trouble breathing, get their inhaler to them, get some albuterol to them, work on them. Amen. Status asthmaticus is what? Severe prolonged asthma attack the bronchodilators are not working on. They're having ongoing asthma attack that cannot be stopped. Pneumonia, it can be viral or bacterial. It becomes fever, chills, and coughing up green or yellow sputum. Fever, chills, coughing up green or yellow sputum. Could have unilateral breath sound issue. They got some kind of congested sound on one side, but not the other. Usually means there's some type of bacteria or virus down there that's made a little home in their lung. It's quite gross. Now, congestive heart failure can turn itself into a respiratory problem. It's respiratory distress secondary to congestive heart failure. Let's break the term up. Congestive, so it's congested. There's a fluid overload. Heart failure. The heart is failing to pump all of that blood out of the left ventricle, so it backs back up into the lungs, causing pulmonary edema. What is pulmonary edema? That is fluid in the lungs, caused by the heart not being able to pump out all that extra fluid. That makes sense? So that'll be the causative factor of CHF. That can turn into a big problem for our patients. You've got an answer for it though. I don't know if the EMR got an answer for it, but I know the EMT-B does. CPAP, continuous positive airway pressure. It forces air down into the alveoli and spreads them open wider, creates a bigger surface area for gas exchange to occur. I'll get you 1 second. For gas exchange to occur, it also forces that fluid back into the circulation of the body. It pushes it right through the capillaries back into the venous circulatory system, and it will cause that patient to increase their gas exchange. What was your question, buddy?
I think I kind of answered it myself, but how would you tell the difference between like CHF and shock? If they both, as far as the skin goes, have the same sort of.
Glad you asked. So shock is hypoperfusion. Hypoperfusion is shock. You can have a CHF exacerbation that is not shock because the blood pressure is still good.
Yeah.
If I was to tie a string around my finger, it would turn red, blue, purple, black, and then eventually die, right? I'm hypoperfusing this finger by an obstruction there. Now, if the heart's not beating hard enough to pump blood to the rest of my body and failing to meet my metabolic demands, I've got congestive heart failure that is now turned to cardiogenic shock. If I get stung by a bee and my circulatory system vessels get this big instead of this big, I've got a problem now with distributive shock. So if I had a water hose here and I'm trying to spray you with it, I just cut it on, it's just gonna spray right here, right? I can't reach my tissue to perfuse it. But if I narrow the diameter of it, I put my finger on it, I'll increase the pressure in the system, I'll be able to squirt you just fine. Your body's working off of a pressure system. It has to have a high enough pressure to reach organs and tissues and cells for them to be perfused. That make sense?
Yeah, so they would present the same way.
It's not
It
John
may be-
Miller blood pressure.
Yeah, exactly. Yeah, exactly. So you will treat them the same way, but you may also want to consider the fact that they may have CHF.
Yes.
Gotcha.
Okay. Flicker go. What?
Could the CPAP be used for anything else or just?
Sleeping.
Yeah, a lot of people with sleep apnea take CPAP.
I got a CPAP. I love it. Wake up feeling like I ran a marathon. I can run a marathon. I don't, but I feel like I can. So pneumothoraxis, we got simple pneumothoraxis. It's basically just a popped lung. Something has popped the lung. You can also have a spontaneous pneumothorax that occurs from tall, skinny individuals that smoke. Just sitting there walking, lung pops. It can happen, yo. Not to me, obviously, because I ain't, I'm not skinny, but what you got?
So you can, as an EMR, we can measure you.
No. Hey, hope, love, transport.
I love fishing.
You can't do nothing about it. Not at your level, the EMR, no.
I have a question on there. It didn't make sense. You just said, well, how would you put the damage on the patient with basically that kind of disease or injury? It was either like,
That's not more like a sucking chest.
Open pneumothorax.
That'd be an open pneumothorax. Closed is just like I'm standing here and somebody, I say I punch Steve in the chest real hard, pop his lung. It's popped, but it's not open. A open pneumothorax means there's a hole out here, it's a sucking chest wound. I would need to do a 3-sided dressing. That way it can still be birthed. Or a chest seal will be great, because an Asherman seal has a built-in flutter valve that allows that air movement, to trap air and create extra pressure on the heart, lungs, and chest. What you got?
So if somebody did have a closed, pneumothorax, how would you try to treat that in the field as an EMR?
Well, let's think about it. It's a simple pneumothorax right now. If I bag them and put positive pressure, extra pressure in this chest, what's it going to turn into? A tension pneumothorax. It's only a matter of time. So you got to be very careful with that.
Can't do anything.
So as an EMR, faith, hope, love, transport. What you got?
How would you get started with the freeway?
As an EMR?
Yes.
Transport.
No, you're like, with the 3-sided.
Over and open and jumper up.
Oh, second chest. Okay. So if I shoot Grayson in the chest, it pisses me off.
Right.
It could happen. Bang! Why is no one making it? So I shot him in the chest, got him up here in the upper left side. And it's making this sucking sound. It's because the air is moving in and out. There's blood flow and stuff like that. So the way I would treat that open pneumothorax is, of course, that 3-sided dressing, but I want it to be able to have air flow just a little bit. That way I don't create a tension pneumothorax. Because if I close it off, what could happen? That air, that pressure here can build up and start to push against my other organs and create a tension pneumothorax. That makes sense?
Right.
My heart and great vessels will be pushed against, so it'll be harder for my heart to pump, and it creates a structural shock.
So we can use any type of dressing for non,
Occlusive dressing,
non-exclusive or inclusive.
occlusive. Occlusive dressing, 3-sided or an Asherman chest seal. Depending on what your company has. Most people ain't gonna spend the money on an Asherman chest seal, even though it's just like slam, done. Instead of like, take this side, this side, this side, we're good.
So clarification on that first, you use a 3-sided dressing with a
Occlusive dressing, yes.
All right. Appreciate it.
Yeah, no problem, no problem. So simple pneumothorax can be caused by trauma. It can be spontaneous, but mainly the thing you'll see is that the patient's now having trouble breathing and they don't have breath sounds on one side. Probably got a popped lung. I was playing baseball and I got hit with the bat. There's no lung sounds over here. That's because the lungs popped. He needs a chest seal. So in the chest, there is lung, chest wall. There's a pleural space in between the two. A pneumothorax is air trapped in that chest wall. Pneumo means air. Thorax means chest. If I had a pneumatic air gun, it's just air, right? So I have air trapped in my chest. Everybody with me? Y'all good? Y'all need a break? Okay. Pneumothorax, hemothorax, hemopneumothorax. Let's talk about it. So pneumothorax means air trapped in the chest. Hemo means blood, means there's blood trapped in the chest. When I shot Grayson in the chest, there was blood and bleeding in that chest. So now his chest is filled up with blood. Now, because of air and blood, I got a hemopneumothorax. Make sense? Cool. Further differentiation about hemo and tension pneumothorax. So hemothorax, the patient will show signs of shock. They've lost blood. They've still got it in them, but it's not in their circulatory system. It is outside of the circulatory system. They have lost blood. You can see flat neck veins, hypotension, and it could be massive. They could have 2,000 to 3,000 milliliters of blood they've lost. Average human body has 6,000 milliliters of blood. They could lose 2,000 to 3,000 right here. That's half. They will be in shock. They need a chest tube at the ER. There's nothing you can do about it, but treat them for shock and get them there quickly. Now, a tension pneumothorax is air in that space over here. That air is pushing against the organs. It will cause the neck veins to stand way up. It'll cause the blood pressure to drop because the heart can't swish like it's supposed to. It will also cause no lung sounds on that side and a sound called hyperresonance. It will sound like, almost like yelling into a fan. hyper resonance, like resonating sound. You just try to do it. I did it in my mind. You have closed pneumothoraxes, open pneumothoraxes. Now, closed pneumothoraxes, we learned is the chest wall is intact. Open pneumothoraxes, there's actually a hole, a puncture, or some type of rip in the chest wall that exposes it to open air. Everybody with me? Okay. Average bag valve mass volumes, the adult one for the BVM can put out 1,600 mLs. We learned earlier the average adult breathes in about 500. And if you give them the whole bag, you're gonna pop some lungs. Paper bag syndrome. That's why we want to just bag till chest rise. Child BVM goes to 500, infant goes to 240. Again, just chest rise. The neonate or infant lungs are only about that big. When you grab this thing, I want you to crab claw it. See my fingers? That's how you bag an infant. Like that. Just enough to get that little chest to rise. Don't pop a baby lung.
So you don't squeeze? You don't squeeze it?
No. Gentle. And if you're ever in doubt, you got children? How would you bag your child? Carefully. Carefully. If you ever have a question about whether you should or shouldn't do something, think about how you would do it if it was your mom, your dad, your granddad, or your child. Because every patient in the back of your box is your family for the next 15, 20 minutes. You treat them like that, you won't miss anything. You won't be tempted to skip steps. I ain't gonna worry about that. We talked about OPAs and MPAs, oxygen, I ain't worried about. We talked about CPAP, so we're in good shape there. So CPAP is non-invasive. It's not gonna hurt them, but there are some indications and contraindications to it. They got facial bleeding or airway trauma, no CPAP. If they are not alert, no CPAP. If their blood pressure is not at least a 100 systolic, the top number is not over 100, they do not get CPAP. CPAP will lower the blood pressure by doing what? That positive air pressure fills the chest. It's blowing it in here, continuous positive airway pressure. What that does is that it puts more pressure in the chest. It reduces blood returning to the right side of the heart. And if they've got a blood pressure lower than 100, it will drop it even more. They could lose consciousness. So blood pressure over 100, not altered. They need to be able to tolerate it. Also, CPAP is great for wet lungs. They got fluid in their lungs, or if they've got congestive heart failure or pulmonary edema, this is great for that. Remember, it pushes fluid back into the circulation and widens the diameter of those alveoli and increases gas exchange. And where is that guy with my sandwich?
I think he drove there to get it.
My God.
That's what I'm guessing.
So suctioning sucks. This little carry portable suction, it ain't worth a doo-doo. I ain't kidding. I've been on so many cardiac arrests where it's like, it's not really working that good because it's a piece of turd. It's not great, but it's better than nothing, right? So you have to know how much to suction, how often to suction and stuff like that. Why is that important? Because you could brain somebody down. So for the National Registry purposes, an adult, you only gonna suction for 15 seconds max and then stop. For children, 10 seconds max. For an infant, 5 seconds max. That will probably be on your registry, possibly. The rigid suction, which is what you can use, is that little Harry Potter wand. The Harry Potter wand we held and played with as the finger button or the air hold where you can get that thing to work or not. That thing's good for chunks of food, teeth, anything big and chunky. What it's not good for is lower airway. So you're only gonna be able to suction the upper airway when you do suction. All right, show of hands, who's EMR, who's EMT?
I study.
All right, so EMT, taking their EMT test in. All right, so the rest of y'all are EMR then, right? Okay, good.
We can do deep suction, we can only do what we see in the mouth.
Okay, so only what you can see. Never want to braid him down or go down farther than the glottis, but you could push something farther down. BLS medications, we talked about albuterol being a bronchodilator, makes the lungs bigger, opens those bronchioles so more air can flow through. Oxygen is actually a drug, believe it or not. It's a drug, a gas, and an element. A drug, a gas, and an element. There is a thing called oxygen toxicity. You can give a patient too much oxygen. It's called absorption atelectasis. We heard earlier that atelectasis means collapsed alveoli. Too much oxygen over a long period of time can cause those alveoli to dry out and stick together. So if they're not open and having airflow through them, the patient could have some problems. Also, those free radicals that you're putting in their bloodstream, you have a lot of those oxygen molecules attaching to hemoglobin and transporting the tissue to do what they're supposed to do. Some of those free radical molecules will go around, they'll bounce off of cell walls and cause damage and cell leaking. There is a issue to giving too much oxygen. So 94 to 99 is our range. Don't want to be up in the hundreds. I don't want to be below 94. Keep it there. Keep it there. No need for you to know about CO2 at this point in your life. All right, so we're about to start cardiology. Let's take a 10-minute break. It's 8:31. Come back to me at 8:40. It's 6:31. Come at me at 6:41, and we'll get back to it. All right, folks, we're back in it. So cardiology, the heart and stuff. Turn the heat on. So again, I'm gonna let you do your own anatomy. Let's talk about chest pain, cardiac causes. Cardiac causes. There's many other causes of chest pain that could not be myocardial infarctions in nature. It could be pulmonary, emotional. You had chest pain because you was emotional. He broke my heart. Oh God. You didn't know that. Profile me. Well, I used to go to Georgia Tech when I worked at Grady around exam time. Little 20-year-old girl having a chest pain problem because of emotions. Her whole life rode on this one test. They put way too much pressure on them kids out there. Great. Georgia State wasn't no better though. It could be vascular, it could be neuro, musculoskeletal, or gastrointestinal. You ready to play the hot wings and got some chest pain? Oh, just me, huh? We done checked out, I guess. You can't even eat meat. Shut up. Shit, I mean, I did. You didn't know the bee before. I wasn't always a priest. Right. So chest pain, most commonly though, for when they call us, when it's crushing chest pain, it could be a myocardial infarction. Fancy way of saying heart attack. Myocardial infarction is a fancy way of saying heart attack. Remember what I said earlier about I'd wrap a string around my finger, it turned red, blue, purple, black, and die? That's because my organic tissue requires blood flow, perfusion, oxygen and other nutrients my blood will transport and carry with it. So the heart's no different. The coronary arteries actually feed the heart the blood flow it needs. And sometimes you live a life of fried chicken and pizza, like all of you are currently eating. You could develop coronary artery disease and lipid buildup. That'll narrow the diameter of your coronary arteries and block blood flow. And just like my finger, your heart muscle will become ischemic, red, blue, black, excuse me, red, blue, purple, and die, black and die. There, that was it. So we want to intervene on this before it happens for our patients. What they need is a cath lab. I don't care if you're a super paramedic or a critical care paramedic or whatever. We don't do lab values in the field. The only way to really know somebody's having a heart attack is to check their troponin levels. That is done with blood. So if you ever work with a paramedic that sits there and thinks he knows the patient's having a heart attack because their 12 lead was clean, it's horse hockey. Only about 40% of heart attacks are MIs, myocardial infarctions. Only about 40% present with changes in their EKG. The only way to really know somebody's having a heart attack is a blood test. Transport your patient to a cardiac capable facility, meaning they have a cath lab, meaning they have a facility where they can go in there and dig that thing out. or put straws in there called stents to have that blood go around it. The number one cause of heart failure is a heart attack. If we don't get that patient to the hospital in time for reperfusion to occur, that means we deal with that clot and either go around it, make room around it, pull it out, or whatever we're going to do. That patient will have heart tissue die. And dead meat don't beat. Dead heart tissue doesn't beat, doesn't conduct electricity, it's not excitable, and is no longer capable of automaticity, which means it creates its own electrical energy. It's no longer capable of any of that. It just sits there kind of useless. Just sits there kind of useless. So heart failure, right versus left. The number one cause of right heart failure is left heart failure. Left side of heart failure is wet. You have wet lungs. Right side of heart failure is dry. How to use the EMT-B treat heart failure. Supportive care. You treat the symptoms you can see, and you give them supportive care. There ain't much you can do for it besides recognition, but recognition is still a good thing. A thorough assessment is still a lot of legwork that the ER doesn't have to do. That buys the patient time. If you haven't figured it out already, EMS is the special teams of the medical world. If you watch football, you notice that the special teams are responsible for ball placement. Every now and then we'll throw a touchdown or kick a field goal, but mainly we're kicking the ball to give the offense ball placement. Your job is to get that patient down the field and set up for the ER to save the day. Every now and then you will save a life and do something cool. However, don't lose track inside of the thing that while I'm a great EMT or great paramedic, that patient needs a cath lab and a doctor with more tools, techniques, diagnostic equipment, drugs, and 8 more years of school than I have to treat him. Your job is to buy them time. Your job is to buy time. So with right heart failure, the patient will usually develop edema, peripheral edema. You ever seen somebody with giant chunky ankles that's swollen? You push on it and your fingerprint stays there? That is edema. That is usually a sign of circulatory failure, and it's usually a sign of right-sided heart failure. It usually indicates that the right side of the heart's not pumping adequately, and the blood will back up back into the venous system. Some patients, you can actually push on their liver. It'll cause an increase in venous pressure, and their jugular vein will actually pop up looking like a thumb. It's really cool. Push liver, bang, JVD. Now, as we talked about earlier, John, cardiogenic shock versus a congestive heart failure issue. I've been called to patients with congestive heart failure or CHF exacerbations where they're having some problems, but I could sit them up high, put them on O2, and that fixed the problem. It was positional. They needed more O2 than their body could actually take in. Now, the problem with cardiogenic shock is that the heart is no longer able to meet the metabolic demands of the body. It's not pumping hard enough or strongly enough to make the blood flow round and round good enough to reach my end organ perfusion needs. Cells need oxygen, water, and glucose to create energy. Constant flow of oxygen or cells will die. If the heart can't pump blood and reach my end organ perfusion needs, cells die. Cells make tissues. Tissues make organs. Organs make organ systems. Organ systems make the organism. Everybody clear on that? Organ systems make the organism. But cells are the catalytic start of it all. Cells do this, and those cells have to be perfused. So cardiogenic shock is basically a failure of the pump to have it meet the metabolic demands of the body. The heart, the pump, the engine's no good. The engine ain't got the power that it needs. So what are you going to do for cardiogenic shock? The problem is they don't have the pressure to meet their end organ needs. They need pressors. Y'all can't give them. You need to call for ALS or get them to a hospital. Now, whatever's best for the patient needs to happen. If the paramedic is 20 minutes off, but the hospital's 5 minutes away, go to the hospital. Does that make sense? So you got a patient here in cardiogenic shock. Paramedic unit is 20 minutes away. Hospital's 5. Let's go to the hospital.
So I do got a follow-up question, man. So what vital signs would, what indicate that?
So the patient will be probably pale, cool, clammy. They'll have a low blood pressure. They'll probably have wet lung sounds. They'll probably have some chest pain going on. They'll probably have cold extremities. They'll probably be throwing some PVCs on their EKG, but that's for a paramedic level. But those are the signs and symptoms you'll be going for. Usually you'll be called for trouble breathing.
Right.
And you get there and they're super weak because the heart is the engine, right? They're super weak. They're super tired. They can't lay flat because there's too much fluid in their lungs. And that engine's not working well enough. So they're showing signs of hypoperfusion, showing signs of a decreased blood pressure and inadequacy of that heart, that muscle, that engine to run the body. That make sense?
It does. So the follow-up to that is what is it possible to write on the board, like what kind of vitals there will be? Because on the test, I did fill out a section, and one of the questions was, it gave me a list of vitals. I said take them to the hospital, but it was wrong.
Without seeing the question, I couldn't really clarify it for you.
Right, you gave me the vitals, and it was like, what do you do with this patient?
So that would probably be an order of operations question. Now, like we said earlier, if normally it's ABC, right? Airway, breathing, circulation, unless there's no pulse. It was probably trying to see if you knew the systemic approach to treating this patient based on the vitals they gave you and what would be the highlighted most important parameter that they gave you. Does that make sense? They're trying to see if you know when to do a certain technique or intervention. Now, you might have been right, but this other one might have been the one that happens right before it. Like if I say, if I want to check circulation, should I check his airway first? And I should know the A, then the B, then the C. It's asking you about C, but they're asking you know A and B first. It's an order of operation question. Does that make sense?
It was more of a, we're trying to impress his phone, and the vital signs, blood pressure was pretty high, his respiratory rate was 128, and that was very like, what to do. First, we have a heart attack.
It very well could have been a heart attack. And we treat patients off of a high index of suspicion. So if you call me for chest pain, I'm gonna treat you like you're having the worst heart attack in the world until I have lab values saying you're not having it. So you call me for chest pain, you're getting chest pain protein. If you call me for trouble breathing, I'm gonna treat you like you're having the worst trouble breathing ever. So I would say have the high index of suspicion and then work backwards off of that conclusion.
By the time those lab values come back, you're no longer your father.
Sign hereby. Sign hereby. So for your treatment of cardiogenic shock, it is mainly identification and transport. If you have a paramedic partner, you can assist them in what they're doing. And I gotta tell you, good paramedics are made better paramedics by a strong partner. My partner at Grady, I would run any call in the world with him. I've done it alone. When I first became a paramedic, I had these fire EMTs that had just gotten off of 24. They didn't want to do anything. They were tired. They were lazy. They just want to drive the truck. Okay, so I'm used to doing it by myself. But in Atlanta, when I had my partner there, I would run anything in the world because he gave me confidence. Because we had, one, been through so much stuff together, we could run a call and not have to even speak because we knew each other so well. And he was so good at what he did. Your job as an EMR and an EMT is to be a good, solid partner. To keep me, the paramedic, from doing stupid things. I will not be offended. And any good paramedic will be like, not offended that you helped him save somebody's life. We're all subject to the power of suggestion. We could all make mistakes. Matter of fact, before I give a drug to any patient, I check to see that it's the right mLs. My partner checks and I check again. It goes through 1, 2, 3 sets of eyes before I even give a drug to a patient. That's how I, knock on wood, have never given the wrong drug to a patient because I observe the 6 rights. Is it the right drug, dose, documentation? Is it the right patient, the right route, the right time? And I check all those metrics 2 or 3 times. I like to measure twice, cut once. Should I take shortcuts with your loved ones? I know you got kids. Who else has got kids in the room? Should I take a shortcut with your grandbaby?
No.
Oh, I shouldn't? I should go ABC 1, 2, 3, not skip any steps? Okay, you do it for everybody else's grandchildren. Hypertensive emergencies, even at the paramedic level, you can't do anything about this. Here in Georgia, we don't treat hypertension in the field. We don't really call it hypertension until we got the patient at 180 over 120. Anything over that's really kind of the real hypertensive range. Some people walk around with a 160 over 110. It ain't really healthy for you, but not really that hypertensive range. These patients could have visual disturbances. They could have neck pain. They could have palpitations. There's a problem with the pressure in the system being too high, though. It can cause other problems. So your body works off this pressure system, right? You ever left a water hose on too long and it forms that titty on it? It has a bulge that it forms, right? No. That is a weakness. Shut up, you've done it. Oh, you turn it off. So it can form a bulge in it. Your aorta and your arteries have areas that could be weakened just genetically. That high pressure system will cause that aorta, that artery to bulge out and eventually leak. This is called an aneurysm when that thing bursts. And this could happen because the pressure in the system is just too high, too long, too often. Usually it's the result of subtherapeutic levels of their high blood pressure medication or non-compliance with that medication, or they just don't take it. That makes sense? They're not taking their medicine like they're supposed to. Not doing it. Where's my clicker? There.
So when you say that even paramedics can't treat hypertension in the field, does that mean that they can't even give them nitro or anything like that?
Depends on your protocols. I've never worked anywhere that allowed you to give nitro for just blood pressure issues.
Really?
If they had hypertension and chest pain, it's a whole nother thing.
Okay.
Whole nother thing. So you gotta be careful when you're
The risk of that is dropping it too low.
too low, yeah. It could drop it precipitously, which is like that. Now we're on the floor. Now we got a shock issue. And if they do have some type of MI or issue where they got to go to the cath lab, they have to have a blood pressure high enough to go to the cath lab to perfuse their organs. You want to see somebody get mad, see a cath lab doctor whose patient you dropped the blood pressure on the floor because you didn't ask a couple simple questions. If you remember, nitro's got some contraindications. Blood pressure has to be at least 100 systolic. They cannot be on erectile dysfunction medication within 24 hours. If they are, it'll drop it to the floor and they could die. They cannot be having a inferior myocardial infarction, which you wouldn't know that from the EMT level, would you? Because you can't read a 12 lead. So see, these are some problems that could pile up. And again, if you got a older male dressed nicely, young female out on a date, he calls you for chest pain, he gonna lie to you and say he ain't taking no medication. Separate the two, because death before dishonor. If I'm 70 and I got me a 20-year-old, I'm gonna lie too. No, I ain't taking nothing, baby. Pull him to the side, sir. This will kill you if I do give you this. All right, I'm taking it. Don't let her know. I won't. That's right. So another problem we can run into with that high pressure system is dissecting aortic aneurysms. The aorta branches off of the heart, comes swirling around here and comes down to a big old trunk of artery that goes down your trunk here. It splits, forms small arteries and subclavian arteries. It feeds the body. The big boy gets a big titty on it, or a aneurysm forms, and it starts to leak. How long do you think they'll live once it starts leaking or tears? Not very long at all. Matter of fact, you could be on an operating table and still might die. Bad juju. Recognition of a dissecting aortic aneurysm is chest pain, or the urge to defecate, or back pain. And they'll say the chest pain, when they describe it to you, will be a tearing sensation. It feels like I'm being torn apart. If it's just dissecting and leaking, there might be a chance to save them. But if it's, you'll know when it finally pops. Why? Well, yeah, I was really watching the Braves. Gone. He's out. He's unresponsive. Why? Because the blood pressure is not there. He's probably going to die.
I transported a patient.
Is it
last
anything that was
week.
dropping? No, it's not there.
She had had 3 dissecting aneurysms since August.
She's a lucky person to be alive.
I transported her because she was out in pleural fever.
Oh, wow. You got problems.
She was questioning about aortic, like abdominal aortic aneurysms. Have you ever heard of an abdominal tourniquet?
You're talking about a Reboa.
Yeah,
A Reboa. Yeah, that's actually kind of a newer thing. It's resuscitation, endovascular balloon, something. Basically, it's a balloon that goes in here. It's an internal tourniquet, and it clamps that son of a gun off, and they can actually do some work and save your life with it. But that's in the OR. We ain't doing none of that. But the Reboa is really cool. Actually, Northeast Georgia up in Gainesville was the first to start using that, as far as my knowledge, in Georgia. So angina is a fancy way of saying what? Chest pain. You've got stable, unstable, and variant angina. Stable is old man out there, man, I'm cutting his grass. Grandson, sorry, Bill, he starts having chest pain. Why? He pushed his body too much. He had a supply and demand problem. His body demanded more oxygen than his heart could give. So the heart got ischemic and was like, ow, this hurts. Hey, quit all that. I'm gonna start hurting you. So he rests, maybe takes a nitro, and it goes away. That's stable. It was based on his effort, his exertion level. Unstable angina is the chest pain stays for greater than 20 minutes, and it's not resolved with that one little nitro, and it just keeps getting worse. That means what? His heart is going more and more ischemic, and there is tissue that is going to infarct and die. It can be injured, then die. Remember my little string on the finger. Tissue needs blood flow. I put a string on my finger, it turns red, blue, purple, black, and dies. That heart tissue is doing the same thing internally. That's unstable angina. Variant angina is spasmodic. Your arteries can do this and spasm shut. How? Usually cocaine. Drugs are bad, okay? Drugs are bad, don't do them. So this is called Prince metal or variant spasmodic angina. So how do you treat these patients? They need rest, relaxation, get their anxiety down. If you have anxiety, what's going to happen to your heart? Increase rate, so you're increasing demand, another supply and demand issue. Relax your patients. Even if you know they're really bad, lie. Looking good, sir. We're doing everything we can. Now, don't tell them they're not going to die or they're going to be living, but do your best to assure them. What does that mean? We're doing everything we can, sir. I feel fine, sir. Don't lie to your patients, but make it seem better than it is. Get creative with it. So you're going to need IV access, but you're EMT-Bs and EMRs, so you can't do that. I'm going to rearrange what I'm saying now.
I try.
With prayer, all things are possible. That's what you can do at the EMR level. You can pray for them. Throw some sage, light some sage back there, and about it. But you can transport them. At the EMT-B level, you can assist them with their nitro. You can give them aspirin. Your paramedic, you can assist him with the 12 lead, which I showed the ones in my EMT class how to put on a 12 lead. And you can even transmit the 12 lead. Let's say you work in Atlanta and you're on a BLS truck or a BLS engine. You still got the 12 lead, you may not can read it, but you can put it on and then transmit it to the ER, and the ER can have it, and the cardiologist can read it. You can still do things. So the nitro, the aspirin, both great ideas. So the MI, I think we've covered that pretty good.
I got a question.
All right, what's your question?
Other than the recovery position, what position can we put them in? Any of these
So any shock patient, you're going to want to put in the shock position. So they're laying supine with their feet up 6 inches. That'll help with gravity pulling that blood back to their vital organs. With any patient having trouble breathing, you're going to put up in a high Fowler's where they're almost sitting 90 degrees up. That's going to allow them to have full chest expansion and any kind of fluid they got will drain down. Other than that, it's pretty much position of comfort, wherever they're best comfortable at. And for left lateral recumbent, that is our airway protective position. You put them on their left side, that keeps them from aspirating, that keeps them from rolling over and puking while they're laying prone and then drinking it up and suffocating on it. Drunk people, Buckhead, Friday, Saturday nights. Hated that. Please put me in the ghetto. I don't care. Just keep me out of Buckhead, drunk bastard. Tell me about cardiac arrest. Cardiac arrest to me, I mean, a lot of people I don't like working codes, but things get real easy. At least they're quiet, you know, I don't want to be talking to nobody all night. So cardiac arrest, pumping and blowing, right? Worst thing can happen is they go into cardiac arrest and you have to deal with it. Compress their chest to 100 to 120 compressions a minute. American Heart has got metrics and objective data that they're always reading and re-quantifying. There is nothing better than compressions. I don't care if you're super medic and you've got healing monastery powders. I don't care. Perfect compressions will save lives. Perfect compressions save lives.
You're not breaking the script, you're not doing it right.
So 100 to 120 a minute, at least 2 inches, allow for recoil. You'll be in good shape. What you got, bud?
Cardiac arrest, same thing as respiratory arrest.
No,
Not-
Can I explain that one? Wait, I think I can answer.
Cardiac arrest is heart stop.
Well,
Respiratory arrest is you can breathe, it stops.
but isn't there apnea? So apnea and respiratory arrest.
That's the breath.
Yeah, the only difference between that one, and the other one is you have to, with cardiac arrest, you have to use. It's called, I know this, it's like you have to put a bag, have a bag on pretty much, or cardiac arrest, have a bag on instantly, and if you have a paramedic, they can intubate them and try to get them to breathe it on their own, but by the machine. Using oxygen, on that type of way, only a paramedic can do that.
so to recap, respiratory arrest is, when we talk about respiratory issues, we have a patient that calls us for a respiratory issue. It'll be respiratory distress, where they're having trouble, but they're still moving air and they're still perfusing their body. Respiratory failure, where they're failing to meet their body's needs. And then we have respiratory arrest, where they're not meeting any needs, they're not breathing. Heart's still beating, but they're not breathing. Now, cardiac arrest is there's no pulse, they're not breathing, they're pretty much medically dead. There might be some myocardial cell activity going on, and we can see that on the EKG. And based on what's going on, I can act upon it with ACLS protocols. Respiratory arrest means they're just not breathing. Cardiac arrest is kind of medically dead. Make sense?
Makes sense.
Okay. All right, so we've kind of covered the chest pain, but here are some symptoms for you. So we got feeling faint, nausea, cold sweats, the chest pain, the left arm, shoulder pain, right into the jaw, the arm. These are all signs of chest pain, but again, let me remind you, there are three different people with autonomic dysfunctions that will not present with chest pain normally. Old people have burned out a lot of their neurons by being old, like Steve here. See grandma in the back. You're old. Women do not present with normal ways of chest pain presentation. They may not have chest pain. Well, my back hurts today. What's going on? Old people, women, and diabetics. Diabetics get neuropathy. They burn out those nerves. They can't even feel their feet. You think they can feel chest pain? No, I'm feeling weak today. Now think of an old woman, diabetic. How would I know she's having chest pain? By putting on a 12 lead, by treating the things, the symptoms I see, and by taking her to the ER for the lab draw of the troponin levels. That's what I can do for her. But again, not everybody presents with all this going on here. They do not. Well, you had chest pain, didn't you? That's what I said. Old women. I'm kidding. She can't fight. She can't fight. I spent too many years on the streets of Atlanta. I got hands. She don't want to do it. I did fight some crackheads. So the main thing they need is reperfusion and pain relief. Reperfusion is that cath lab going in there, either roto-rooting that thing out. They might stab through it with a wire, inflate a balloon, and snatch it on out. Kind of like if you got a wife at home and you got to clean that drain for her, which is the worst thing in the world. Like some mutant spaz thing coming out of there. They snatch that some gun out. Pain relief you can't really do much about, but the nitro you can give as the B can relieve some pain. Why? Constricted coronary artery, bigger coronary artery, less pain, right? There we go. What is the aspirin doing for me? Aspirin does not lyse clots. Aspirin doesn't bust clots. It's not a blood thinner either. Please spread the word. It's not. What it does is aspirin inhibits the chemical thromboxane A2, which causes the platelets to not stick together. So while it doesn't bust clots, it doesn't let that clot get any bigger. Aspirin saves lives. ESO did a study in 2019 showing that patients that got aspirin earlier had a 23% higher chance of not dying. That's good, okay? What was your question, bud?
No, I was just gonna answer it. I was gonna be like, yeah, aspirin basically, coats the blood, red blood cells, keep them alive.
I like it. So we about covered ACEs, same thing. We talked about aspirin, nitroglycerin. We've already talked about that. So again, they gotta have, what you got, buddy?
Before you get off of cardiac arrest,
Yeah.
just talking with different people on all the test levels. I've had EMR student, EMT-B student come to me and ask and tell me that they've never, ever heard of ROS. So we're talking about.
It was
Return of spontaneous circulation.
Y'all hear about that?
Heard of
who?
Not in the EMI class?
Yeah, we just-
Let's talk about what.
I'll let my student answer that. What is wrong? What's wrong?
It's return of spontaneous circulation.
Return of spontaneous circulation.
Return from spontaneous circulation.
ROSC. Return of spontaneous circulation means you have worked the cardiac arrest and achieved enough metrics or compressions to get that patient to have their own heartbeat again. That should be covered in all curriculums.
No, he didn't do that.
I will tase any student of mine that says it wasn't said. Say it when y'all.
Now, this class,
What you got, buddy? Come on.
So I don't see you guys taking notes, but there's several things that he's going over. And folks that have come to me and said, I've seen this on the test, no one's ever said that. Right side and left side of heart failure is 100% on the test. If you're answering the questions that you're supposed to be answering, a mere passing or passing question is, we know the difference in right and left side of heart failure. You're talking about a lot of these syndromes, Cushing's syndrome, and a lot of things that he's going over, check, it's in the vital signs. So you have to know the vital signs. And that's on any level.
So for you folks at home, Commander Tyrell's in here and he's explaining that a lot of the students that he's seen take this test are saying that they are actually seeing a lot of these questions about ROSC and about cardiac arrest and about these vital signs with left and heart and right failure on the test. So if you're at home, this is kind of what we were saying in the classroom. I like it.
Yeah, I know when I took my test, it said I have ROS. And it was like, patient had a 65-year-old male has ROS. What do you do next?
So, it's funny because even paramedic students are confused by this. It's funny watching new paramedics, like when they get a patient's pulse back, or they get a ROSC or return of spontaneous circulation, they're like, whoop, what do I do now? I didn't think I'd get this far. So the main thing we need to do is make sure they don't become hypotensive, keep the blood pressure up. Make sure that their respirations are managed with capnography, which again, this is a paramedic thing, but you can assist them by bagging them, keeping that SAT over 94%, keeping that CO2 level at 35 and 45, start therapeutic hypothermia protocol. And of course, keeping all that going on is going to be plenty of work for you. So for you, the EMT-B or EMR, keep them cool, keep them breathing. And again, you do that whole sage burning thing we was talking about and drive faster. I'm kidding about the sage. Don't burn sage.
How would you treat hypotension?
As an EMT-B,
Where?
you can. At the EMTI, EMTA, or paramedic level, you can do a fluid bolus. At the paramedic level, you can do a vasopressor, which is a alpha agonistic agent, which will cause the arteries to do this squish so tight that blood pressure has no choice but to jump up. And also with some of those drugs, they're inotropics, which makes the heart beat harder and faster, which is what a cardiac arrest patient would need, right? So again, it's good to have an ALS partner to go through that kind of stuff and to do those interventions. But if you ain't got it, compressions, bag them, tag them, run them to the ER, that's still life-saving. There's nothing that'll do more for that patient than good compressions. So if that's all you got to offer, good compressions and good ventilations, that's good enough. Get them to the ER where they can have that kind of stuff. There's nothing worse than having a bad call, right? It sucks. Like, let's say we work at pediatric arrest. I'm always haunted by them. Can't help it. What's even worse than a bad call is having a bad call and not knowing what to do. So that's why I'm glad you're here to learn what to do, at least within your scope. You know, all I can do is bag and do compressions. Okay, we'll do it perfectly. I heard a man once say that if I'm gonna be anything, I want to be the best at it. If I'm gonna be a street sweeper, I'm gonna be the best street sweeper I can be. So at your level, EMT-B, EMR, be that good, know your scope, know your stuff, and do your job. And you'll still do life-saving things, I promise. EMTs save paramedics. Paramedics may save lives, but EMTs do save paramedics. Again, my partner at Grady made me way stronger by one, giving me confidence, by him being reliable. And I would run anything in the world right now with him. He couldn't fight for nothing though. He was terrible with psych patients though. Usually I was the one doing all the holding down while he went and got the drug. And that's how that went. All right, so let's take another 10-minute break. We're gonna start on the trauma section. And we'll be back at, come back to me at 9:40. All right, let's talk about trauma. Before I get any further or deeper, let me remind you that trauma is a surgical disease. No patient needs you being on scene, being a little rescue Randy, thinking you can save the world. You're not a thoracic surgeon. You're not a brain surgeon. You are an EMT, EMR, or paramedic. Trauma is a surgical disease, which means it needs to be treated with a surgeon. 10 minutes or less on scene time. Wrap, package, and go. This is load and go. Trauma does not need to be played with on scene. How fast can a patient deteriorate if they got an internal bleed that you don't catch? Pretty darn fast. The pelvis can hide 3 liters of blood. Would you see it? No, not until they're hypotensive and in decompensated shock. So let's move on. It didn't click like I wanted it to. There it is. So heat stroke. The body's gotten too hot, bruh. Too hot. Heat stroke versus heat exhaustion. The patient's gotten too hot. So the patient needs to be cooled down. Your first move is to take them
Out of the environment.
out of the environment. Shades, but good. Cold ambulance, you can hang meat in, even better. So it is a state law. You can take this to the bank that your ambulance's AC must work. Not just for your benefit, but for your patients. You got a heat stroke patient. Yeah, I know. I've seen the look. I know. I get it.
Yeah.
That whole thing was.
Let me tell you, you got rights, exercise them. It's not only for you that you do this, it's for your patients. I need to hang meat back there in case I have a patient with heat exhaustion or heat stroke going on. I need to, first thing to do is change their environment. Secondly, I can do some active rewarming technique, cooling techniques by placing cold packs around their core, the axilla, around the cervical region, and in their groin area. So groin, underneath the armpits, behind their head, on their neck. That's what you do, EMT-B and EMR. That's what you do. The difference in heat stroke and heat exhaustion is the body is now stroked out. It now has more problems. They will not be sweating anymore. Why? No longer compensated. They are no longer compensated. They're headed towards a severe emergency now. Severe emergency. Now, at the paramedic level, we can talk about internal cooling with cold IV fluids, but that ain't y'all's level yet. Hypothermia. Hypothermia, less than 95 degrees. The body's supposed to be 98.6. You got below 95. You're technically mildly hypothermic. Mildly hypothermic. Losing the ability to shiver is bad. Muscular movement creates heat. Your body shivering is that muscular movement creating heat. If they stop shivering, that's bad, okay? Also, the shivering is going to burn a lot of glucose. Make sure that you're checking their sugar. If they stop shivering, it might be because they're out of energy reserves as well. Moderate hypothermia, 82.5 to 89, and severe hypothermia, 82.4 and below. Now, when they get hypothermic, there's also a risk for them to go into spontaneous V-fib. Spontaneous V-fib, which means the heart no longer pumps, it quivers. It's not beating, it's quivering. They're dead. You need to do CPR. Cardiac arrest time. Now, another thing can happen is if you got a hypothermic patient and you jostle them or move them too fast or too hard, V-fib, right into cardiac arrest. You have to be very delicate and gentle with these patients that are hypothermic, that are a little icicle. I'll also remind you that nobody is dead until they're warm and dead. There are studies that show that if I go drop Isaiah into a cold frozen lake right now and hold him under the water for an hour, there's a chance of still getting him back, even if he's been under the water an hour. The cold will slow the metabolic processes of his cells. They will require less energy, oxygen, all that good stuff. He can still be resuscitated. Nobody's dead until they're warm and dead. What you got?
So I do have a question. So, follow up to what you just said. If you were drowning in the lake, do you start rewarming procedures or you just go straight to CPR?
I'll go straight to CPR because I need that heart to move blood around. But then after I got more help on scene, I'd work on warming him up. One of the first things I can do for him is what? I can have the back of that ambulance into a sauna. I have to be able to control the temperature of the environment my patient's in. If they're too hot, I need to make them cooler. So the first thing is cold ambulance. If they're too cold, I need to make them warmer. So the first thing I do is hot ambulance. It should be actually uncomfortable for you. It's so warm. It should be actually uncomfortable for you. It's so warm. Like it is now, now that I put a coat on. So that's where we're at. Any questions about that before I move? Warming, cooling, these things are easy to come by. Don't think of it as too complicated. I tell paramedic students who are worried about reading EKGs, hey, at the end of the day, if it's too fast, the heart's too fast, slow it down. It's too slow, speed it up. It don't have to be crazy complicated. If they're too cold, make them warmer. If they're too hot, make them colder. Have I lost anybody? Was that difficult? I think.
Yeah, I'm completely lost now.
Go stand in the corner. Sick of your attitude. So types of shock: hypovolemic, hypovolume. Hypo is a prefix, comes at the beginning of a word, indicates intensity, direction, color. Did I say direction? Okay, all that. So the prefix hypo means low, below normal and inadequate. Hypovolemic, volume. The patient has a low volume of blood. Now, all of you probably was like thinking that this is somebody that got stabbed or shot, right? I can see why you think that, but hypovolemic shock doesn't always occur because of a trauma. I could give you all, let's say I sneak some Visine into Grayson's Mountain Dew over there. He starts crapping for the next day or so. He don't take enough fluids in, he could be hypovolemic. How about a baby that is not taking a bottle but keeps having diarrhea? They could be hypovolemic. A burn patient who's had fluid shifting from interstitial spaces, they got them big bowls full of fluid, they can be hypovolemic. It doesn't always mean a trauma and blood loss.
A landscaper has been out working in 105-degree heat.
A landscaper that's been out working, he could have lost a lot of his fluids by sweating them out.
A older person took a little blue pill, was given some, nitro.
I'm not gonna bite into that one, no. No.
So if you're hypovolemic, could that lead to heat stroke? Because you sweated out all your sweat and you can't sweat anymore, so you're hypovolemic. Lost a lot of fluid.
I guess in a roundabout way. I mean, it'd be hard to sweat out that much fluid, but it's possible. I mean, I went to the gym and covered a soap shirt,
Yeah,
you know,
full buckets.
so you could sweat out enough of that, but also just breathing. The average adult breathes, when you breathe out, there's heat and moisture and water droplets. The average adult breathes out about 1,800 mLs of fluid a day. Now imagine somebody that's anxiety ridden or has asthma that's breathing 25, 30 times a minute. They're blowing out air and water. So hypovolume means they have low fluid volume. It's very common in hemorrhage, dehydration, stuff like that. They'll probably have hypotension, tachycardia, anxiety. How do we fix it? You replace the volume with fluid. But at the EMR, EMT level, you can't do that. Call for ALS or transport to the hospital. Or if they can drink something, here, sir, drink this. That'll be a while before it actually hits their circulatory system, but it's starting the process. Make sense? Cardiogenic shock, we've already kind of talked about. This is shock. When the blood pressure falls, now we're in shock. Shock is hypoperfusion. What does perfusion mean? The means of getting blood flow to tissues and cells, right? So cardiogenic shock means the pump ain't worth a fart. It ain't got the power to meet the needs of the body. That is it, simply. Result of cardiac output compromise can be from CHF, cardiac failure, could be from dead and dying heart tissue. That's it in a nutshell. How do you treat it? As an EMT-B and EMR, again, we can talk about prayer and burning sage and transport, because that's really all you can do. But you can recognize it and help your paramedic by setting up his IV, putting on his 12 lead. You can help the paramedic treat it. And you can suggest a hospital that has cardiac capability right around the corner. Well, I really want to go to the other hospital. It's got better snacks. But they can't save him, buddy. Let's go to this one that can.
Definitely going for the snacks.
Now, I'm not gonna lie. Obviously, I'm a snacky person. But patient care comes first. We have to choose what makes us uncomfortable sometimes. Give you an example. We get too used to hitting the easy button. Let's say a patient's having a stroke and you're over there by Killendale Hospital, which has no stroke treating capabilities, but you're about to get off and it's right by your station. So you choose Killendale. It's actually called Hillendale, but everybody calls it Killendale. But you choose that hospital so you can get off on time. Did you do good patient care? No, because now the patient's going to sit there. They're going to transfer them out after an hour or two, and the patient's lost their window for reperfusion. You need to just kind of eat that one, get off a little late, and take it to where they need to go the first time. Stroke patients go to stroke hospitals. Trauma patients go to trauma hospitals. Heart patients go to heart capability hospitals. What you got?
Sorry, for a stroke, wouldn't you want to get them to the closest hospital no matter what?
No.
Because
What can they do? So there's a small window for you to treat a stroke. They usually get either tissue plasminogen activator, which is a clot buster drug to get that clot out of their brain, or they'll have to have a neurosurgeon go in there and pull the bastard out or clip the aneurysm. If I take them to a hospital that can't do either of those things, they're just going to sit there and that window's closed. Now the patient will leave the hospital with a useless left or right side of their body. But if I take them to, let's say, Grady, they'll meet me at the front door with the stroke team, and within 5 minutes, they'll be on a CT scan table and they'll be treated in 10 minutes. And then that patient can walk out of the ER and hug their grandkids and go back to work next week or in a couple weeks. That's why you don't want to go to the closest hospital. It's scary. I admit, sometimes it's fear that motivates EMTs and paramedics to choose the hospital they go to. Well, it's closer, and he could deteriorate. That's what you signed up for, buddy. If he deteriorates, he'll go into cardiac arrest. Now it's kind of easy. I'm just going to pump this chest and bag him. It's easy if it does that. Don't let fear motivate you. Don't let the easy button motivate you. Do what's right for your patients. Who loves a mama? You love your mama, John?
Oh, yeah.
Would you want somebody to not take her to the right hospital just because it was closer?
Oh, absolutely not. I put some hands.
Oh, it's throwing hands. Would you want somebody to transport your mom somewhere that was not their appropriate facility? They couldn't help her. They just sat her in the ER and did nothing but call a transport company to come get her and take her to the right hospital. You know how I know? Because some of the calls y'all run is the exact same thing. I wasn't gonna say it on the recorded line, but yeah, yeah. So that is part of your job. Right hospital, right place, right time. The only time I choose the closest hospital is if they're actively in cardiac arrest. Now, if they're actively in cardiac arrest, fine, go to the closest hospital. Or if it's something where they're about to die, you get it? Now, what about a pediatric? Pediatrics need to go to pediatric hospitals unless they're about to die. The problem is if I take a pediatric to Grady, they don't have the equipment to treat them. They don't even have a blood pressure cuff to check their blood pressure. This is the problem. That's why they need to go to Hugh Spalding across the street where they got that kind of stuff. Make sense, everybody? Cool, cool. Now, obstructive shock is in the form of something physically obstructing the heart and the body. So we're talking about things like tension pneumothorax, where there's air trapped in the chest and it's compressing the chest and the heart and the great vessels, and it can't beat well enough to meet the needs of the body. Blood pressure drops, we're in shock. A pericardial tamponade is when the sac that surrounds the heart is full of fluid. That fluid's doing what? Keeping the heart from expanding and contracting and pumping blood, so it's obstructing the body and forming shock when the blood pressure falls. The way to treat cardiogenic shock is to take it to an ER for a pericardial centesis. They'll stab the sac in the heart, suck the fluid out. Paramedics used to do that in the field, but we had too many people stabbing people in the heart like Dracula. So now they do it in the ER where there's an X-ray machine to guide their movements. Make sense? Cool. Some other types of shock, we got neurogenic, anaphylactic, and septic. These are your big space shocks. Your big space shocks. So, quick look. That's my 120/80. That's my blood pressure. That's my veins when they're the right size they're supposed to be. But what if I have something that makes that vein much wider and bigger? That's my 80/40 blood pressure because it's so much bigger. The pipe is bigger, so the pressure is lower. The pressure is lower. If my pressure is lower, I can't reach my target end tissues. My cells will go unperfused. The patient will be in shock because they're hypoperfused. It is shock when the blood pressure falls. Neurogenic shock occurs when there is unopposed parasympathetic response. So you have the nervous system, that is the central nervous system and the peripheral nervous system. Peripheral divides into the somatic and autonomic nervous system. Autonomic nervous system is sympathetic, your fight or flight, or your feed or breathe. Parasympathetic and sympathetic fight all day long. One's trying to slow the body down and make all the vessels big and beautiful. The other one's trying to speed the body up and make all the vessels tiny. They end up getting right in the middle, and you have the perfect 120/80 blood pressure. All your body's metabolic needs are met, and life is good. When you have a spinal injury, bang, you snap the spine or break it or hurt the spinal cord. What happens is that parasympathetic nervous system is gone. You lose all sympathetic tone. Now the parasympathetic nervous system, who's that feed or breathe, that guy that wants to make all the vessels big, nobody's opposing him. So the blood pressure will fall because the pipe gets so big. Did I lose anybody? Is that good? With me? Get a bunch of nods. Is that nods of I understand, or nods of just keep moving, or?
Oh,
I like honesty. Cool.
I understand. Keep moving.
I don't believe you, but I'm gonna keep moving. So that is your neurogenic shock when there's a spinal injury causing mass vasodilation. Anaphylactic shock, a bee stings you or something you're allergic to gets in your body. That foreign antigen is a protein that your body is going to act upon in a very much over-exaggerated immune response. Your body, when something invades it, will release antibodies. Those antibodies, specifically IgE antibodies, are the ones that will be in this mediated cell response. These antibodies will come and degranulate the mast cells, releasing histamine, causing the veins and pipes to get big as hell. Now, you can have an allergic reaction and not go into anaphylactic shock. Let's say a bee stings your finger and it just turns red and swells, just your finger. Localized allergic reaction. Now, when that finger and your skin and your arm starts to get hives and you start to itch, you start having trouble breathing, feel like my throat's closing up, bro. That's an anaphylactic reaction. When it involves 2 or 3 body systems, now it's anaphylaxis. It is actually not anaphylactic shock until the blood pressure falls. Now we're in anaphylactic shock. That patient needs the EpiPen, EMT-Bs, the EpiPen. See if they, what's that?
EMR's can be fucking too.
Y'all can?
Yes, you
I
can.
don't know what the hell y'all know. We're gonna talk anymore. Okay, so y'all can give an epi, look at y'all giving EpiPens and stuff. Big one now, hell. So EpiPen, stabbing the vastus lateralis or the rectus femoris, the big thigh muscles. Hold it in for 10 seconds. That's it. It works. That'll save their life. Septic shock. You can be septic and not be in shock. the diabetic with the infected foot, he's septic, he's sick as hell. But it's not shocking until that blood pressure falls. So those bacteria, it gets in the bloodstream, and the cytokines and other inflammatory processes cause a systemic inflammation. And of course, the pipes get really big. When the pipes get really big, the blood pressure goes really low, and the patient's hypoperfused, and hypoperfusion is okay. Soft tissue injuries. A puncture or a penetrating wound is just that, something that's penetrated the skin. Usually it's sharp, like an ice pick, a knife. I had a guy stab somebody with a sharpened chicken bone one time at the Macon State Prison in Montezuma, Georgia. Yeah, that's right. I worked EMS down in Mennonite Land with all the Yoders. Tell you what, they're the best department I ever worked with. No lie. You know what make the difference? They're a bunch of volunteers, but they love their community. You have to love your community to get up at 3 a.m. for free and go help somebody and get in the fire engine or get in the EMS box. I didn't do it for free. I ain't like them that much, but they did it and they were the best at it. I've worked across the state. Nobody was better than some of these volunteers I've worked for. That's because they took pride and ownership in what they did. So when I moved to Atlanta a couple of years ago and started working at Grady and Atlanta Fire, I adopted Atlanta as my home, as my city. This is my community. I took ownership of it and I take pride in working there and for them. So wherever you work, take pride in what you do and take ownership of your position and try and do the best job you can. I don't know why I went off on that rabbit trail, but somebody needed to hear it, I feel. Anyway, stabbing people, puncture, penetrating trauma, that's bad, okay? Now, anytime something from the outside world goes into the body, there is a possibility of infection. Let's say I shoot Grayson again for talking smack to me. You think I'm gonna do it with a clean bullet? No, I'm rubbing the dirt first. Get all kinds of germs on it. So, do you think people in prison are stabbed with clean shanks? I mean, it was a toothbrush. It's meant to clean things, but it's not cleaning.
I mean, it's toilet.
It's hidden in the prison wallet, so it's probably really dirty.
I mean, it's toilet clean.
I don't know about that, sir. I don't think I can prescribe to what you're saying. So how do you treat these type of things? Expose the wound, clean it, control bleeding, bandage the wound. Depending on the location, you may even have to do wound packing. Did y'all learn that at EMR level?
We went over it, but we never really.
Okay, so we make a little monkey ball and then we jam it in there and we keep jamming in it. And once the hole is full of pretty much toilet tissue, we hold pressure on it till the bleeding stops. Sir? Wound packing, yes, sir. Okay, so we pack the junctions, tourniquet the limbs. Pack the junctions, tourniquet limbs. Make sure we know that.
So anything you can't tourniquet, you pack.
Pretty much.
Most of
Let's not tourniquet the neck. Unless they owe you money.
the time. You got my $50? No?
So what about avulsions? Avulsion is basically a flap of skin that has been torn off. Put it back where it's supposed to be, bandage it, go to the hospital. Amputations. There's a missing piece of their body. Find it, put it in some cold ice, not directly on the ice, in a plastic baggie on the ice. Take it with you. They can reattach it usually.
Follow-up question to that.
Okay.
What about water?
No, not water.
So there's some practice questions that are like, we'll say ice, and then it'll be like ice and water, and then it'll be like water.
Well, let's think about it. There's an exposed, open, let's say, arm in the water. Those open vessels and cells will be permeated by that water and it will damage them. It'll cause them to swell and pop. We don't want that.
Like a finger.
And not even a finger. Put it in a plastic bag, you put that on ice, go to the hospital,
Like it's on top of ice or under the ice?
on top of it.
They can't get too cold.
Do not put it in water. I said it live.
That is
recording.
one of the that's one of the EMR questions on the test, but they word it in different ways, so you gotta pay attention or you'll miss that one.
So for clarification, just on ice, on top of it, on water.
On ice.
But you
So
can
finger on the
put it in a
rocks.
plastic bag, you can't put it in water?
What?
If you got a cylinder bag, you can't put it in water?
Let's not put, no water ever.
Even
No water.
Keep it dry.
Never- I repeat, no water. No water.
little bit of water.
No water.
There's
Zero.
ice in it, then it's kind of bound to get water in it, but.
How fast you driving?
Exactly.
You shouldn't be out there very long. 10 minutes or less. Trauma is a surgical disease. 10 minutes or less. You shouldn't have a problem with leaking water. No water. Oh, it actually says at the bottom, do not immerse amputated part directly in the water. Don't do it.
Directly,
Directly said that.
directly.
I stole this slide.
Just like also do not put it directly on the ice. So therefore, if you still have a barrier between the water and the body part itself, it should be okay.
No water.
Keep it dry.
Josh, thanks for your time.
Thanks,
Good luck
buddy.
for you guys.
Hey.
No water, no water.
IT.
No water.
No water.
No water.
No water. So since most of you ain't got ice packs anyway, just get the cold pack and put the thing in a plastic baggie and put the cold packs on it. You're not gonna be able to really keep it like surgically cold anyway, but just a little cold is better than nothing, right?
You got that cup of ice that you were working on, driving.
Not at all. No,
Shove it in there and put it on.
not at all. No water.
No water inside.
What's up?
For like a scalping, in the chest and the knife still in, do you, because I know you're not supposed to like remove anything.
I'm getting to that.
Okay, but if it's in the chest, would you, in there in cardiac arrest, would you remove it?
I would. Because otherwise I'm gonna saw into that chest.
Repeat that, you said you what?
So any impaled object, you stabilize in place and do not move it unless it's in the cheek, in the way of the airway, or in the chest, and we have to do cardiac arrest. Only if they're in cardiac arrest will you remove it, or only if it's in their cheek or airway. So if let's say I need to get in their airway and intubate them or something, or like I can't do it if it's in their cheek. And if I got to like bag them or something, it's not gonna work. I can't seal. That covers my next slide of impaled stuff.
I do got a follow-up question. What if it's like a child goes through a window and they have the glass in their
Leave it,
side? So,
leave it,
so just leave it.
leave it.
Do you apply pressure and leave it, or?
You can apply pressure around it to make sure it doesn't bleed out around it, but if you remove it, it could have been wedged up against an artery, and you moving it out, it's gonna cut on the way out. So it could slice an artery and they could die. We don't pull anything out of them,
So even if it's like glass?
even glass.
Glass still cuts, bro.
I mean, with glass still breaks.
That's why we stabilize them and we strap them down, and that's why we just make sure they don't move anymore. And if I have to, as a paramedic, I'll make them go night-night. Night-night. Go night-night.
See you after surgery.
Again, stabilize, don't let it move. So we got hemorrhage classification. A capillary bleed is bright red, slow, just flows out. A venous bleed is kind of steady flow, it's kind of gushing, dark red color. Arterial blood flow, it is bright red, it's squirting out very far, and it kind of looks like it's going to a beat, because it is going to a beat. A heartbeat. Types of shock. We got stage 1, 2, and 3, and 4. This is based on how much blood they've lost. It's sometimes hard to tell in the field, to be honest. But the stages are basically the level of compensation they're in. What does it mean to compensate? It's to make up for something, right? So if you're compensating in compensated shock, your body is either losing blood or in shock, but the heart rate jumps up, respiratory rate jumps up, your body starts shunting blood to vital organs, and you're still able to maintain your perfusion needs because you're compensating by the heart rate being so fast. Decompensated shock is, well, I'm starting to decompensate. It means my heart rate's going to drop, respiratory rate's going to drop, eventually the blood pressure is going to drop, and then I'll go to irreversible shock, which irreversible means it's irreversible. There's no coming back. It's over. You did. We already talked about all these. There's another slide for y'all to look at. All right, so chest and abdominal trauma, very low velocity, high velocity, medium velocity, blunt chest trauma. So blunt means there was no penetration, but it was like a solid object, let's say a baseball bat. It's blunt trauma, but it can break ribs. It can cause spinal injuries. It can damage organs. You have hollow and solid organs. Your spleen, you can live without a spleen, but it's the reservoir for where your old red blood cells go to die. And it houses a lot of blood. You may can live without a spleen, but an acute splenic injury can cause acute death from hypovolemic shock. So this blunt chest trauma, it can kill you. Now, what about penetrating trauma? It means something has been shot at you or stabbed at you in the chest. Low velocity is knives or something sharp. You stab someone, that's low velocity. Medium velocity would be the handgun. High velocity is your rifles and some machine guns. That makes sense? High velocity machine guns, deer rifles like that. Medium will be your what? Handguns. Low velocity be bow and arrows, knives, spears, whatever somebody's got.
That Finnish
Huh?
guy, that guy in Finland shot all those people with that bow and arrow a couple weeks ago.
Didn't hear about it.
Didn't hear about either. What? No.
Yeah, there's a terrorist attack in like, was it like Finland or something? There's-
Finland's terrorist attacker is a
Killed
bunch of
like-
bow and arrow
killed
people.
like 6
That's
people.
funny.
Is that what it was?
It's
Yeah.
like a terrorist attack in 1850s.
They don't have guns.
That's interesting. Some more chest and abdominal trauma. So diaphragmatic rupture is, the diaphragm is a hollow organ that's dome shaped underneath your lungs. That's exactly what makes your chest expand and contract. A damage to that can do what? Cause you to stop breathing, results in increased intra-abdominal pressure. You could actually hear bowel sounds over the thorax. You'll hear gut sounds in the chest. The only thing you do for that is transport. Evisceration. Evisceration means what? I've sliced your guts and the guts are hanging out. Do we push them back in?
No.
No. We don't push the guts back in. We cover them with wet dressings and we transport for a trauma surgeon to put them back in their right place and order. Because if you push them back in randomly, this part of the jejunum will be up here by the liver and it's not supposed to be. You can cause a bowel obstruction. Not good, right? So basically cover with wet dressings and right on. Now, a flail chest. A flail chest is when 2 or 3 ribs are broken off. And when the patient breathes, you can see paradoxical motion, which is their chest is not breathing in sync. Instead of rising and falling like this, it's rising and falling like this, like a seesaw almost. So paradoxical motion is that. Flail chest, you treat that with positive pressure ventilation, either a CPAP or a BVM. CPAP or a BVM. Traumatic asphyxia, when you are compressing the patient's chest and they cannot get full chest expansion, their face will turn red, then purple, and they will eventually asphyxiate and die. They will asphyxiate and die. Purple red appearance, need to treat the ABCs and roll on. Now, commotio cordis is actually not that uncommon, but it does happen. This is when blunt force trauma hits the patient in the chest at the latter half of the T wave of their EKG. Basically what happens is their electrical wave in their heart, it hits at the right specific perfect time, causes the heart to go from beating to trembling, quivering, V-fib. The patient's in cardiac arrest just from blunt force trauma. It can happen with a baseball, hockey puck, or even a fist. If you hit somebody in the chest at the right spot and time, it will kill them.
There was a magician that died of that. He was like betting that somebody could punch him in the chest and wouldn't do anything to him. Then like somebody punched him in the chest, it was a drunk dude. And he punched him in the chest and just dropped there immediately. For what magician? I think it was Houdini actually.
I thought he died from drowning.
Is that what it was?
Yeah.
No, he dared someone to punch him in the chest.
Yeah, it was Houdini.
I don't know. I don't keep up with magicians, you nerds. What's wrong with you? I'm here to teach EMT class, not talking about Houdini.
Yeah.
All right, so what about sternal fractures? So we have the manubrium, the gladiolus, and the xiphoid here, making up the sternum. It's possible to fracture that thing with a direct blow. Now, what happens when bone fractures is that those fragments are usually kind of sharp, and a lot of movement can cause some gouging, some cutting, some damage to structures that they're supposed to protect. The function of the skeletal system is to protect vital organs, to regulate serum calcium levels, and to create erythrocytes or red blood cells. So if these kind of bone fragments are broken or damaged, then guess what? They can cut and cause bleeding. You can see sternal fractures with blunt force trauma. A bent dashboard or bent steering wheel usually indicates that the chest hit the steering wheel and bent it. Now, one had to give, and it looks like the steering wheel may have bent, but what happened to your chest is a whole nother matter. Did it break the sternum? Did it pop a lung? Did it break some ribs? Did it cause a pericardial tamponade? You get to find out on this episode of What the Hell Happened? So soft tissue wounds, closed wounds, a contusion, a bruise, ecchymosis, all fancy ways of saying bruising. Ecchymosis and contusion is a fancy way for saying bruising. Now, if I come up here and punch John Stafford in the shoulder, it will leave a bruise because those capillaries in his deltoid will be ruptured, but it will not penetrate. It will not penetrate because it's blunt force trauma, and that usually doesn't penetrate. Now, enough mass and enough kinetic energy, it could penetrate. If I drop a motor on him from 10 foot up, it will penetrate painfully. So, closed wounds. Hematoma is a collection of blood. Kind of looks like a goose egg. You ever seen somebody get a goose egg from hitting their head? That's a collection of blood. Does it? I wouldn't know. I don't hit my head on things. Sounds like you need a helmet.
Yeah, you crayons too.
You're in the right profession.
It's pronounced crayon. It's a crayon.
I hear. Crayon. All right, so an abrasion is pretty much just scraped skin. Laceration is a tear, split, or incision. It's a slice. Anybody confused about any of this? All right, I've already covered the shocks. I don't know why I got it in here 3 times, so I'm gonna keep moving. It is important, but I don't have the time to do it. I actually teach off of space repetition model, which my students in here can tell you is I say something, then repeat it, and then repeat it some more, then I repeat it again, because repetition is retention. So this is probably why I did it, but I don't have the time tonight. We already talked about pericardiocentesis. All right, let's talk about head, face, and neck. A Lefort fracture is a fracture in the face where the zygoma or the maxilla or even the orbitals can be cracked. You got Lefort 1, 2, and 3. You can see how it moves in sections. 1 going up a little bit more is Lefort 2. Lefort 3 involves even the orbits. Now, something you need to watch out for with a facial fracture is airway bleeding. If this bone is cracked, there's going to be blood going where? Into their mouth and throat, and you got to keep it out of their trachea and their lungs. That's always a trick, especially if you've got them spine boarded and you're having to suction constantly. It's annoying, but it's better than dying, at least on your watch. What about head bleeds? Subdural, subarachnoid, and epidural bleeds. A head injury can cause a head bleed. Subdural is a venous bleed. It's usually slow, can take hours to a day or so to actually appear. Anybody that has a head injury, you need to have them CT scanned to make sure they're not having a head bleed. You don't know, you don't have x-ray vision. Head injury could be slow head bleed. This will kill them. They need to be seen. A subarachnoid bleed is deeper into the brain itself. It is actually going to be in the brain, intracerebral bleeding. Epidural bleed is an arterial bleed, usually involving the middle meningeal artery. This one you'll see immediately. There'll be signs of head bleed immediately. So signs of increased intracranial pressure like unequal pupils or Cushing syndrome or fluid coming out of the nose and ears, that kind of thing. A systolic blood pressure climbing up while the diastolic remains the same. Bradycardia, where the heart rate goes down. Irregular respirations, that is signs of increased intracranial pressure. Epidural bleeds you'll see and know really, really quickly, I promise. Any patient with a head injury though, please get them a CT scan. There's no way to know without it. Now we got coup and contra coup. So as you see the guy in the figure here, you all see the thing up there? Yeah. So let's say you're in a wreck and your brain slides forward. The first part of it hits the front of your skull. And as you start whipping back, the back of your brain hits the back of your skull. That's coup, contra coup. Bang, bang. Kind of like shaking a BB in a jar. Make sense? Your brain's the BB if you didn't get the analogy. So there are types of amnesia, retrograde and antegrade. No recall of the events before the injury will be retro meaning behind, throwback, and antegrade meaning you can't create new memories. Usually this is short-lived and you go back to normal eventually. There are cases where it could be long-lived. Then we have basilar skull fractures, where things like battle signs and raccoon eyes will appear. I would advise you to learn the fancy way of saying battle signs. Battle signs means there's blood behind the ear. There's bruising behind the ear. It's indicating that there's a crack in the base of the skull and it's flowing back there. Anytime you have a bruise or something, it means that there's blood flowing in that area. So there's blood flowing from the back of the skull into behind the ear area. The fancy way of saying that is retro-auricular ecchymosis. Raccoon eyes is known as bilateral periorbital ecchymosis. It's associated with orbital fractures and basilar skull fractures. So again, we talked about Cushing's triad being a sign of increasing the cranial pressure. And again, that's just a triad of 3 different problems that are occurring because of the increase in the cranial pressure. Bradycardia, irregular respirations, and then systolic increase of blood pressure. So what's going to happen is that we have the Monroe-Kelly doctrine at work here. There is a fixed volume of brain, blood, and cerebrospinal fluid in the head. The brain has all the stuff in it it wants and needs. But if you have cracked your skull and there's a bleed inside your brain, or the brain is swelling or anything like that, you're going to change the relationship of that volume, right? It will increase the pressure inside the skull. That pressure will not allow blood to flow into your brain like it's supposed to. So the body's first response is auto-regulation of your blood pressure. It will increase the systolic to meet the demands of the body. That make sense? I don't believe you, but okay. We're going to talk about raccoons and battle signs. So spinal cord injuries. You have axial loading, which of course is compression of the spine. If I threw you out of the back of a, let's say a 30-foot building and you landed on your feet and it didn't break your ankles, that pressure would cause your vertebrae to do what? Compress together. It'd probably hurt, right? They squish together. It would suck a lot for you. That'd be bad. You have central cord, anterior cord, and Brown-Séquard injuries. I would definitely say study those and make sure you know what they are exactly. I'm gonna try and start moving a little bit faster because we are running out of time. Getting towards the end of what I can do tonight. So subluxation or dislocation. Dislocation is what? It's out of its right place. Usually it can be a shoulder, a finger, some type of area that's supposed to be in a joint is no longer there. It's out. Now subluxation is a partial out. So it's partially dislocated. How do we fix it? We don't. We let the ER fix it. Everybody see that? It is best for them to do it because they got pain meds and you don't. Keep that in mind because it's going to hurt. So. Burns. Burn, baby, burn. So burns happen a lot. People out there with these damn fried turkeys on Thanksgiving. Well, what was you thinking? I don't even like turkey, to be honest with you. I'm a ham guy. I'm not a big fan. So populations at greatest risk, the very young, the very old, firefighters. They're at risk because they're around fire a lot. What? Firefighters are around fire?
That's weird.
Strange times we live in. Well, the very young and very old because they could not deal with that type of injury to their body as well. So we've got burns we need to learn about. The patho of the burns we're talking about is thermal, electrical, chemical, and radiation burns. Thermal burn is just heat. A thermal burn is the heat is just too much for your body to deal with, and it causes a burn. You have first degree, second degree, and third degree, or superficial, partial thickness, or full thickness burn. Superficial, of course, is your first degree. You could get a sunburn and have a first degree. Second degree burn is the most painful. It also forms these big fluid-filled boils. Third degree or full thickness burn is all the way down to the nerves. There's usually no pain because the nerves are gone. And you can also see this white chalky substance of the adipose tissue being flayed, burned off.
They don't call it thickness on the test.
Oh, I always call it thickness. Go on. What do they call it on the test?
Third degree.
Third degree?
Let's say. I mean, you still had partial and whatnot, but it was just,
Unless something changed, it'll be first degree, superficial, second degree, partial thickness, full thickness will be third degree.
it didn't use the word thickness. But they still had partial, superficial, and whatnot. It's thickness.
So there's us repeating all the information there. I would advise you, I don't have time to go over the rule of nines, that's a whole lecture in itself, but you need to learn the rule of nines, memorize it, because if you have a burn patient, you'll need to know what percentage of their body is burned. That's important, okay? Parkland burn formula really only applies to paramedics and people that can start IVs. Won't bother you with that. Inhalation injury, that's a problem. Because years back, when a house burned, it was just wood burning. Nowadays, it's synthetic plastics releasing all these chemicals that are very dangerous to inhale. When wood burns and most things burn, it releases carbon monoxide. Carbon monoxide has a 200 times greater affinity for your hemoglobin than does oxygen. So you will have a relative hypoxia created by this carbon monoxide inhalation. You will suffocate to death inside, on the inside. So anybody that's been in a house fire that you pulled out or are treating, you need to be thinking that they probably inhaled some carbon monoxide or carbon cyanide. Most of the stuff built today is made of plastic, and PVC pipes are made of plastic. And so is a lot of the stuff in these people's homes, in your homes. When plastic burns, it releases carbon cyanide, which is poisonous and will interrupt the mitochondria of the cells and their energy processes, and also stop you from creating energy, but also from breathing. Another form of suffocation. Another form of suffocation. So inhalation injuries, too much heat and smoke in your throat will cause that tissue to degrade and be damaged. That tissue will swell, fill with fluid, and close off your airway, and you're gonna die. Okay? So hopefully your paramedic can go ahead and take the airway before that happens, or you can get to a hospital before that thing closes up. Because after that, the only option will be a surgical airway where we stab a hole in their throat and throw a tube in there. So acid versus alkali burns. There are chemicals out there that if they get on your skin, they will burn you. Okay. These things will burn you. Let's say things like Drano. Don't want to keep that on your skin. So acid, the burning process lasts just a minute or two, will cause coagulation. That means what? The whole tissue and all that blood and those vessels will just become like soupy. Looks like beef stew today. And alkali burns, the burning will continue for minutes to hours. It will cause liquefaction, necrosis. You'll be melted. Fun, right? So how do you deal with those things? Flush, 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 water, 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 hospital, hospital, transport, transport. Now, what if it's a chemical burn and it's like powdery substance? Brush it all off first before you put water on it and spread it and make it worse. If it's powdery, dust it off. Of course, you're wearing gloves and wearing a mask and doing all your PPE, BSI bull crap, so you don't get hurt, but then you can put water on it after you've brushed it off.
So when we were taking the EMR final,
Yeah.
one of the questions was, there was a patient that worked
Man.
for a pharmaceutical company that had powdered fentanyl spill on them.
Powdered fentanyl, that sounds great.
Yeah,
That's a narcotic. You can spray that on me all the time.
and And the question was, what would you do first? Wipe it off or flush it? Well, we were talking.
I would scrape it off into a little baggie and put it in my pocket.
Yeah, but
The answer was to immediately remove the water.
yeah,
Okay.
but we.
You're not gonna hurt him with, fentanyl's not gonna burn him. You know, now you can absorb fentanyl through your skin topically and then it causes narcotic overdose, but it's not gonna cause a burning issue. Now, if it's let's say some type of toxic powder that when you put water to it, it activates it and it starts to burn the patient, that's bad, okay? But fentanyl, no, he might even enjoy it.
He
will have no pain.
Make it like a paste and try to make it like stick to their skin or something like that, but
Or make them absorb it.
make it absorb it quicker.
Definitely. I would say if there's any kind of powder on anybody, dust it off. And then we'll spray it with a water hose or a pressure washer if you got one in the back of your truck. I never worked anywhere that had one though. Damn it. All right, so about scuba and diving injuries. Air embolism is a problem. Basically, you need to take them to hyperbaric chamber. That's really what needs to happen. Steve, my boy. Oh, Steve. You know, I don't have the time to really dig into this a whole lot. Basically, there's with air embolisms and diving accidents, they need a hyperbaric chamber. I don't know what else to put about on that. I don't have the time. So hazardous aquatic life. The ocean don't like you. If you get in it, things will sting you, bite you. All kinds of bad stuff will happen. So anything that stings you in the ocean, you need to have the mindset of don't pee on them. I don't know where y'all learned that. Don't pee on patients. It ain't cool. No peeing on patients.
Oh, cool for the jellyfish things.
Yeah, that's what.
I know they told you that, but don't do it. My mother thinks that vinegar fixes everything. Well, that's a myth. It's not true. Alcohol helps to hurt. Alcohol only helps to hurt on the inside. So for the patients that have been stung by some type of aquatic bastard, hot water, as hot as they can stand, will neutralize the toxins there. Hot water, as hot as they can stand. Yes, I know your urine is hot, but it's not as hot as we need it to be. And it's still very unsanitary. Don't pee on patients, okay? Coral snakes, ticks, coral snakes, red on yellow will kill a fellow, red on black, venom black. That's an old, I think, Boy Scout saying, but basically one's a king snake, one's a coral snake. One will kill you, one is not venomous. I don't want to find out either way. If you see a snake, burn the forest down. Get all of them.
Yeah.
It's worth it. So snake bites, with treating a snake bite, you're going to want to put some compression on it, but not tourniqueting their blood flow. You want to tourniquet their lymph flow. The lymph system will draw fluid out of tissue and take it back to lymph nodes. What you're going to want to do is most lymph movement and actually blood movement is correlated by muscular movement. Now your heart, of course, is pumping blood everywhere, but your muscle movements actually help move your blood around. Now, definitely your lymph movement is a lot of because your muscles are moving. So whatever part of them is bitten, stabilize it, splint it, put a tourniquet on there just tight enough to not let lymph fluid move, and don't let them move it. Mark the time and then divvy on up to the hospital. Call them as soon as you know you have a snake bite so they can begin preparing the anti-venom. Anti-venom is at most hospitals nowadays. They've all got it. They just have to, it takes a time to make it. It's not a fast like, kind of like I'm making a shot of a Jaeger bomb. It ain't gonna be that quick. So we need to have the time and preparation for this. Sea life, ticks. They got 3 problems they can have: Lyme disease, tick paralysis, and Rocky Mountain spot and fever. All these are bad, okay? How do you get a tick out? You do not tweeze it out. We don't burn patients, okay? You can put alcohol on them and then use a scraper. Scrape him out. Another thing that some ticks can do is they can make you allergic to red meat.
I have a friend who that happened to her. She got Rocky Mountain spotted fever and now she's allergic to red meat.
What a terrible way to live.
Terrible life.
I'm just gonna have to be sick, I guess. All right, so sea life, remove barbs if they're visible. Spider's the devil, okay? If you see one, kill it. I've already trained my 4-year-old, my 1-year-old to kill every spider they see.
Have you seen one of the new ones now?
There's a new spider.
Yeah, the new
I don't
invasive
want
one in Georgia, the Joro spiders.
The huge ones.
They're like,
And what they look like, what they call
they're called Joro spiders. They're invasive. They're like this big. They're like hugely invasive in North Georgia.
I haven't seen them, but if I do, they die.
They're working their way south. They're nasty.
So
She's like, hey, Florida, you got residence here?
black widow bites.
Boy, we're not going down there.
Black widow bites, they are poisonous. They do cause pain and muscle spasms, usually not deadly. Brown recluse, the little fiddleback spider, he has a necrotic tissue toxin. So wherever he bites, that tissue there will usually spread and die. You don't have the ability as a EMT-B or an EMR to fix this. So just recognize it, kill the spider, and run to the hospital.
If it was a brown recluse, I just grab a knife out and just cut it out.
For you, no patience. So fractures, we have different types of fractures. I think that y'all should know that pretty well. We're running low on time. I would definitely say that you should know your types of fractures and the kind of injuries they have. Types of impact, I think that one's good. So compartment syndrome, it can be associated with crush injury, but also it can be associated with muscular injuries, and even sometimes athletes will get this. So around every muscle you have is a form of connective clear tissue called fascia. And that fascia surrounds all your muscles. What it does is it compresses the muscle and the microcirculation around that tissue, and it kind of forms an internal tourniquet. The only way to get it off is the ER does a fasciotomy. They split your tissue open and they cut the fascia open so your tissue can flow freely. So your tissue can flow freely. That's what we got going on there. Let's see, solid organ injury. We're talking about liver and spleen. They're big areas of stuff. What you'll notice mostly is hemorrhage and hypovolemic shock. Treat them for shock. Blast injuries. Hell yeah. So we got different types of things coming with the blast. Initially, when the blast goes off, you've got the burn of the explosion. So they can have burn injuries. They're also propelled through the air. And potential shrapnel. And then whatever they get thrown into. So you got 4 areas of opportunity for trauma to happen. Burns, shrapnel, being thrown, and then getting hit by something like being thrown into a wall. That sounds painful. Lots of bad stuff going on there. We talked about eviscerations, pediatrics. All right. No, my pen's leaking. We got about 20 minutes left. Y'all take a 2-minute break and we're going to get as far as we can tonight, okay? 2 minutes, because I got to go to the bathroom. All right, sports fan, we're back for the last bit of our little overview here. I do not have time to finish all of this tonight. I did try. I hope some of it helped you, though. I hope you got what you needed out of it, at least for the most part. Again, this wasn't going to be comprehensive no matter what we do. You still got to study. Still got to main thing you need to do right now is be taking test after test after test, finding weak areas and strengthening those weak areas. So we talked about PEDS being a weak area for EMS, and that's a fact. One of the main things is that pediatrics are not little adults. They are completely different anatomically. They are different anatomically. Their airway, their larynx is actually higher up in the body at around C3 to C4. Their tongues are proportionally bigger, much more apt to be an airway obstruction. Their jaw, their head's actually proportionally bigger. They got big old heads. This is one of the reasons why when we treat a patient with an airway issue, we roll some towel and put it underneath their shoulders, put them in the sniffing position. That way we can fully extend and open their airway and not cause them injury. So we got some pediatric differences here with the respiratory system, cardiovascular system, skin and body surface area are different there. Their tidal volume is proportionally smaller. I'll tell you right now that if a pediatric is having an issue heading towards cardiac arrest, if a ped's in cardiac arrest, it is 95, 99% of the time going to be because of a respiratory issue. Respiratory issue. They go down because of respiratory. Their hearts are strong. They can compensate and work for them for a long time. But once they start to deteriorate and become decompensated, they're going to go quickly. Most of the time, it is a respiratory issue that has occurred. Most of the time, it's respiratory. So for a pediatric, a baby, if their heart rate goes below 100 beats a minute, bag them. If their heart rate goes below 60, start compressions. For a baby, this is your neonatal resuscitation guidelines. Still 100 to 120 per minute for compression. Still going down a third of the depth of the chest. Still allowing for recoil, but making sure we're bagging them. Now, the difference between one provider versus two. One provider CPR, still that 30-2 ratio of breaths to compression. But there's two of y'all, it does change to 15-2.
If you're just bagging them, it's like 40 to 60 breaths per minute, right?
There it is. 40 to 60 breaths a minute is a target because that's what their normal breathing rate is. On this PowerPoint, and if anybody's real good with tech and can help me find a way to get this to all of you, I'll do it. Look at it after we're done. If you can all get a hold of this, I mean, that you'll have this in your hands. I can't email it. It's far too large. I've tried. And I couldn't even post it on our Google Classroom for our class because it's just too big. You can compress it?
Yeah.
I'll let you try. If we can do that, we'll get everybody that's in this course or in this video tonight, we'll get you a copy of this PowerPoint and let you have some kind of study reference guide.
Real easy. Bad thing about compressing, sometimes you can lose data. Or you can just.
You're not gonna get it at all otherwise, so.
There's that. We're gonna talk about some anatomical differences and that. So here's a big area for the croup, the kids. We got to differentiate between croup, epiglottitis, and bronchiolitis. This is where a lot of people have issues with. So laryngotracheal bronchitis is the actual name for croup. Usually viral. So croup is viral, epiglottitis is bacterial. Low-grade fever for croup, high-grade fever for epiglottitis. Usually 6 months to 4 years old for the croup patients. It's usually got a low-grade fever of under 104. They've got inspiratory stridor and the barking cough. That is one of the tall tale signs of croup versus epiglottitis. Most of these emergencies occur at night and it's usually cold outside. You can treat them with cool mist, humidified oxygen, and for the paramedic, they can treat them with the racemic epi. Epiglottitis is bacterial, high fever. The big tall tale sign of this is they do have stridor, but they got drooling. Drooling is the key. Drooling usually means epiglottitis. Now, this can happen at any age. More common with kids, obviously. But the epiglottis is a tiny leaf-shaped flap that covers your trachea and usually prevents you from swallowing food. Sometimes you can make a mistake, though, and actually accidentally gag on some water as you're drinking it. It's happened to most of us. Liars. So the epiglottis's job is that thing becomes inflamed. It hurts to swallow. The kid will begin to drool. Here's what you don't do. You don't mess with the epiglottitis kid. You don't irritate them. You don't agitate them. You don't put your fingers in their mouth. You do not agitate them. You put blow by oxygen near them and you run to the hospital because this is an airway emergency that could kill them. This is a serious life threat. Some EMS services even have paramedics where they are contraindicated to intubate them if the kid goes out because of how irritating this will clamp that thing up to where they can't get a tube through it. Do not mess with epiglottitis, kids. Remember, high fever, bacterial, and drooling. Everybody with me? Now, bronchiolitis is actually pretty common. It's usually viral. The bronchioles got mucus in them. They're inflamed, and they got a hacky cough. Could turn into pneumonia. Usually just treat it with blow by oxygen and some bronchodilators.
That's the one from RSV, right?
Usually it's from RSV. Here's a picture of an epiglottitis kid. They've got the epiglottis here. The vocal cords are those white V things there. And this epiglottis on the right is that thing inflamed. See how narrow the airway is here now? It'd be hard to get air through that. And it hurts for them to swallow, so they end up drooling. Now, meningitis, the registry loves to put meningitis questions on there. If you see a patient with a headache, stiff neck or nuchal rigidity. That's the fancy way of saying stiff neck, nuchal rigidity. We're looking at a meningitis patient, high fever, stiff neck, headache, and petechiae or purpura. This could be life-threatening and kill them. You could also catch it, so put an N95 on. You could catch it. Meningitis is bad, okay? The meninges are little coverings that cover your brain. You don't want them to get inflamed and necrotic. Pediatric assessment triangle. This is how we assess our peds here. This is how we look at them. So Noonan's saying that they saved it to the drive. I don't know, Noonan. I don't know how we're going to do this. We're going to try and figure it out, though. So appearance, it's still ABC. Appearance, breathing, and circulation. Appearance is if I come in there and this kid is being held by mama here, like, hold it. So if I approach this kid and he's all pissed off and he don't want to talk to me, and he's putting up a good fight, that's good appearance. Now, if I approach and he's like slumped over and slumped over, he ain't got no energy, he's not putting up a fight, and he comes right to me, a stranger, that's a problem. He should have some stranger anxiety. He shouldn't come right to me. His appearance, how he appears, how he looks, how he is approachable, that kind of thing. His affect.
So pretty much if a child wants to succeed, I mean, you automatically know there's something wrong.
If it comes right to you, it's altered mental status, bro.
Well, and that could also depend, it could just be how they are.
Could be. I got 9 minutes. So.
Let's just go, let's just go.
Let's just go. Now work of breathing. How hard are they working to breathe? That's a question and an answer you need to have. Are they just breathing normally like me and you, or are they actually having to fight for that air? Again, what is the number one cause of cardiac arrest in pediatric population? Respiratory issues. If he's fighting to breathe, he'll be soon fighting for his life, and then so will you be working extra hard. And then the circulation to the skin. Perfusion is a big deal to peds. They got to get their blood flow, bro. They got to get it. Now, we don't usually have the ability to really check their perfusion status with a normal blood pressure cuff, because some places don't even carry them. I'm willing to bet I could walk in that bay and not find a pediatric blood pressure cuff. We rely on their skin color, temperature, moisture, and their capillary refill time. The real way to read pediatric perfusion status is their capillary refill time. You should be able to squeeze your little finger, let it go, and then it should return back to its normal color within less than 3 seconds. Make sense? Medical section. Oh, you got a
So
question?
it's 3 for kids, 2 for adults? This is a number less than 2 seconds.
Because we were told to.
Yeah.
Go with 2 then. Okay.
2
Anything less than 3, so 2 would be in there, right?
I thought that anything more than 2 would indicate like a less than 90% SpO2 rate.
Possibly. But you can also attach an SpO2 and read it.
Not down to the kid though, could you?
You can put it on the earlobe with a big toe.
Oh, really? I
Yeah.
didn't know that.
Yeah, we have special,
Pediatric pulse ox, yeah.
Oh, cool.
And all it's doing is reading what if there's something attached to the hemoglobin. Now, pulse oxes can lie to you. Because why?
Carbon monoxide.
Carbon dioxide or something else could be attached to that hemoglobin. It's just reading if something's attached. All right, medicine, medical section. Whew. Altered mental status. You should have already memorized AEIU tips. If a patient is altered, it will be because of one of these things. Alcohol, are they drunk? Encephalopathy, epilepsy, insulin, overdose, uremia or a UTI, trauma, infection, psychogenic stroke or syncope. One of these is causing this altered mental status. One of these is causing your altered mental status. You can use this to rule out what's going on. Also, your GCS. You need to know your GCS. I'm going to be completely honest with you. Whenever I go and retake registry, I learn GCS to take the test, and then when I get back in the field, I just drop it because I don't have so much room up here. Because the software that we use in the 911 center in Atlanta, if I just type in what they're doing, it'll give me the GCS. I'm kind of spoiled that way. So I'm not gonna waste the capital on it, but for your test, you will need to know it. There's gonna be specific questions on the GCS, and when you transport a trauma patient to a trauma hospital, one of the first things they're gonna ask you is, what's the GCS? That determines the level of response that they're gonna give you. What's the GCS?
I don't think that our us EMRs know the GCS.
I don't know, learn anyway. GCS is a Glasgow Coma scale. It's evaluating their neurological status. Even a cucumber has a 3. 15 is the highest, 3 is the lowest. Even a dead body will have a 3. And you can remember that the eyes, the motors, eyes, verbal, and motors. So exterior, every value meal is worth $4.56. Perfect eye opening score is 4. Perfect verbal motors is verbals is 5, and then perfect motors is 6. So right now, if I'm talking to you, you're looking at me, you're answering my questions correctly, and you're following commands and stuff, you have a perfect 15. A patient with a 10 is missing some things though. They might not be awake, might be altered, might be drooling, might have all kinds of things going on. Now, decorticate and decerebrate posturing is usually a brain stem injury or increased intracranial pressure. That pressure in the brain can climb high enough to where there's a hole at the base of your skull called the foramen magnum. When that pressure gets high enough, your brain will herniate and try and push itself through that little hole. So imagine an object this big trying to go through a hole this big. Doesn't compute. They'll start to posture. Posturing is decerebrate and decorticate posturing. Decorticate is when they posture in like this, they're going toward the cord. Decorticate is towards the cord. That'll happen first. Decerebrate is their arms are spreading wide like this. They're not seizing, they're posturing. When the arms spread wide, that's a late sign. That means they're getting ready to fly to Jesus because it's over. They've herniated too much. That brain pressure is too high. Unless they have a neurosurgeon on board with you right there, it's possible they're going to fly away to heaven, okay? Now, appendicitis, main thing I want you to know about this is it's pretty common. We're talking about right lower quadrant pain between the right lower quadrant and the top of the hip, right about here. This is called McBurney's point. Pain that is there with nausea, vomiting, and sickness. We're talking about possible appendicitis. The appendix is inflamed. We don't actually really need it to survive, but it does collect some bacteria there. And if it ruptures, all that bacteria goes into your gut. We're talking about peritonitis and then sepsis, possible septic shock, possible death. They need a surgeon. You can recognize it and you can take them to a surgeon. Psychiatric disorders. I'll probably close on this because it's one of my, I don't know what I'd call it, but I have so much experience with this, it's not even funny. My specialty, working in the city of Atlanta, I have had hundreds of street fights. I didn't want them, not all of them, but it does occur. These people have acute psychosis. A lot of them wind up on the street because they have nobody to take care of them. They can't afford their psychotic meds. They go crazy. When a patient is endangering themselves or others, it's time for you to take matters into your hands, because I showed my class a video of negligent EMTs that caused the death of a psych patient because they didn't take him seriously. They were disrespectful, sort of racist, and they did poor patient care that caused his death. His name was Paul Tarashuk. I dare you to look up the video. It's 11 minutes worth of a police body cam video in 2018, just a few years ago. The young man was a 25, 26-year-old Indian guy from New York or New Jersey. They found him on a tractor, butt naked, helicoptering. Okay? I want you to imagine that for a minute. So that would have been your first clue. There's a psych patient on board, but he was compliant. He was obeying them, but they treated him like crap. They said there was nothing wrong with him. The deputy drives him 18 miles across town to the county line, kicks him out of his car. The guy runs into traffic, is hit by a semi, and of course he died. Your job, if you're called to a scene, is to evaluate patients for need. Now, was there anything you could do for that psych patient? No, but you could have took him to a hospital where you could have got professional help, counseling, and or medication to help him come out of his psychosis, because he was having a schizophrenic psychosis event. So what I'm going to tell you about psych patients is you can't always avoid a combative patient, but your job is not to hurt them. You're not here to hurt people. Reasonable force is using just enough force to subdue someone without hurting them.
So you can't punch them, but you can bear hug.
You can bear hug them and keep them from hurting you and others, at least until we can sedate them for their own good. Now, I ain't telling you sit there and get beat up, no, but we're not trying to hurt people.
Might get bit.
This isn't UFC. I've had diabetic patients whose sugar was low, punch me in the mouth. Do I gotta show them how much of a man I am and whoop his old butt? No. I don't have to prove to him anything. I'm here, that's somebody's granddaddy. And as soon as I gave him D50 and his sugar came up, he was the nicest guy ever. Would not stop apologizing. All I said was, you got hands, it's fine. Not bad. This is gonna be a hard job to do if you can't hard to deal with patients, combative patients. I've had guns pulled on me, I've been spit on, and I've been in a lot of street fights. I've been lucky, I've been blessed to not ever get really hurt. But again, I did it for my patients. You have to kind of know what you're signing up for. And so others can not die. Sometimes you are in some dangerous situations. We do teach scene safe, and every decision I made was not always a scene safe decision. I'm not telling you to break the safety culture that most services run nowadays. I'm gonna tell you that some of the decisions I made were emotionally charged. I hope you're not as gullible as me, because I had a call where a little girl was screaming and the car was on fire. What am I gonna do, brother? I'm gonna snatch her out and do what I gotta do. I got cut and burned for it. I don't regret anything. But we're teaching you the National Registry standard, which is safety first, safety first, safety first. I'm not telling you to do anything stupid out there. I'm just telling you that I did things a little differently sometimes. But again, I was emotionally charged. I knew what I signed up for, and that is to do no harm, to help people, to mitigate risk, and to save lives. I'm going to end with this because I am out of time. I will do my best to get this PowerPoint to you. So Heracles said that out of every 100 men, 10 shouldn't be there, 80 are just targets, 9 are the real fighters, and you're lucky to have them, for they make the battle. But 1 is the warrior. That 1 is the warrior. I'm asking you and telling you that if you're going to be into this profession and be part of my people, you have to be that 1. And that 1 is somebody that's going to put yourself in danger's way. Okay, I got spit on. I don't have to prove it. A diabetic man punched me. I was in East Point, Georgia, when I went to a place and then I walked in, grandma's dead. She dead. I got a gun pulled on me. You gonna stay with my grandmama? Now, was I in real danger? No. Could I respond negatively? I could have. I knew he was the real patient. Oh, I was strapped. I could have gotten out of there, I promise. I'm telling you though, I knew I wasn't in real danger and that his anxiety was through the roof and that I had a job that he was the actual patient. So I treated grandma. Hey, buddy, we're going to take care of grandma, okay? Let's go ahead and load her up. Go ahead and start compressions, buddy. It was for show. I admit it, to save our skin and to keep him from, getting over anxiety. But he was the real patient. So I'm going to close with that. I want you to be the one. Set yourself apart. Remember why you did this. Your motivation, your motive. Remember your why. For my students, the first thing you wrote me was your why speech. Your little essay on why you started this program, why you want to be an EMT. Grasp onto that, remember why you started, and use that to propel you through and pass this test. I wish I had more time to give, but I'm out of time. I hope you had a good time tonight. I appreciate you being good sports. Y'all have a blessed evening and good luck on your exams.
Thank you.